is something not very difficult. In a medical practice, he may not necessarily say that I am depressed. If he says that, it is of course easy, anyone can diagnose depression. But there are some tips that I will give, which very often, there are symptoms which are not explained by the current medical illness or any known medical illness, which should warn you in an individual, that too middle-aged plus, that he could well have depression. The severity of symptoms, what he says, seems to be out of proportion to what otherwise that illness would perhaps predict by way of various laboratory findings, etc., etc. His illness seems to be severer than what I would have otherwise expected. The course gets changed over course of time. Unexpected change of course. There was a person who was admitted with a mild stroke. He had a dysphagia, expressive dysphagia in the ward, and he was discharged. To be discharged, 4 or 5 days later, his speech had become much better, and of course he had no motor symptoms, but he was plagued with the fact that he was not able to really understand what others said. They had some difficulty in understanding what communications that were going on. But he was doing very well. And on the 6th day or 7th day, when the discharge letter was written, the family settled the bill in the morning. Towards the afternoon, he said, he started showing that I'm not able to speak. I'm not able to speak. He started showing, but he didn't say it. And the neurologist thought, okay, we'll hold on for a day or two. In a day or 2 or 3, the course had changed and the symptoms of depression started coming. Although we might call it dissociative symptoms, but these are all symptoms of preluding to a depressive episode emerging in this individual. The person has had a reaction to the illness, which has been told, but this reaction continues for longer than what you would have expected. Then, of course, this is again to be considered as a major depression. And of course, you have to make sure that whatever depression that is expressed and symptoms lasting for 2 weeks or longer and producing more disability, severer forms of symptoms, and his course has changed and he is not sleeping well, he is not eating well, he is not taking medicines regularly, you should all think that a full-blown depressive episode has happened and you have to suspect and then treat the condition. Yeah, like I said, there are some symptoms, a constellation of symptoms that have been described in depression, a mood of depression. You see this person weeping, crying off and on. He expresses hopelessness and a very low self-esteem. I'm not worth living, suicidal thoughts, guilt, I don't know what I did. I have been given this disease in this period. He is probably very retarded or very agitated. He could be having very poor interest in day-to-day activity, including caring for himself or the medicine that he has to take. Appetite is lost. And even the weight could be reduced, and he has sleeplessness, significant sleeplessness. You are forced to give some medicines in the hospital. There is a lowered drive for sexual activity. There are poor concentration. A fatigue is another very common symptom. Retarded and agitated, as I already said. Menstrual changes are also noted in these people with the depression. So a constellation of symptoms, 5 or more symptoms, typically is considered as a major depression. 4 or fewer symptoms are also called as a minor depression. The minor form of depression lasting for 2-3 years, we also call it as dysthymia or dysthymic syndrome. So having seen these things, evaluate the person thoroughly, and you have to see how severe is the condition, particularly when the individual has got suicidal ideas, biological disturbances. Yes, of course, he needs more serious attention as far as treatment is concerned. But most conditions that you would come across in medical practice would be under the section of what we may call as mild depressive episode. It won't be very severe. Unless, of course, there was a pre-existing episode of depression in this individual, and this medical illness would have caused a recurrence, and it could be as severe as it was in the past. If it was not so, more often than not, the depressive episodes are usually mild in these individuals. And when you are treating a mild depression, there are some simple tips that you can follow. You have to promote physical activity if the physical condition permits it. And typically, I prescribe yoga for these people with mild depression. I also ensure there are so many medicines that they would be taking which may not be necessary, which you as a physician would be able to better decide whether these were required or not. And you have to listen to the individual. Like Dr. Gangwar was saying, listening is half cure. Listen to the individual, and much more so when the individuals have psychological symptoms. And of course, you have to give a reassurance. Reassurance does not mean you have to falsify, you have to say what is fact, but the fact that is said in such a message which actually communicates the individual the right message with the degree of confidence that he needs to have in terms of the treatment outcome that it is going to give. Satyam bruyat, priyam bhuyat. Na bruyat, satyam apriyam. Priyancha nanratam bruyat. Don't say something that is a lie just to please the individual. So these things have been told in our Subhashitas. All these things are very helpful in medical practice, the ATCOM module in particular. So there are people who facilitate group interactions. There are groups that have been formed in HIV groups, cancer groups, and the host of those things, alcohol, drug abuse related groups, where when they all discuss their relations, their problems, their symptoms, they will feel I am not alone. There are people with me, and I feel I'm going to get better. And of course, if there is a medical condition, I'm sure all of you, although I would say this to my psychiatry residents, I don't have to tell you, but I'm sure you're already applying your mind to correct the medical condition. Medicines in my moderate and severe depression, I'm giving you only 3 medicines here. I'm not giving a big list of medicines. In fact, there are as many as about 50 odd antidepressant medicines that are available. Something that would be reasonably safe. The SSRIs, among them, my preference is to use sertraline, 50 to 100 mg. And if there is a hepatic insufficiency or renal insufficiency, I use a lesser dose, about 30% if there is a hepatic insufficiency. And most of the SSRIs are reasonably safe, even if there is a renal insufficiency. But I would still start with a lower dose and go up for them. Mirtazapine is a very useful drug. The only caution is I don't generally prescribe mirtazapine to people who have a known hypertension and getting medicines for hypertension. It is fairly safe in hepatic insufficiency or even for that matter renal disease. Nonetheless, a common thumb rule is I use a lower dose than what the others. Bupropion is a very good drug. It's a very good drug which produces more activity in a person who is lethargic. And of course, the end stage renal disease is a place where you have to perhaps make sure that the medicines is used in caution. Otherwise, it's a reasonably safe medicine. You also have to consider when you want to have a collaborative care. When I'm saying collaborative care, you want to involve the psychiatrist in your hospital if he or she is available, or you're going to consult him. When is it needed? If there is a known past history of a psychiatric disease, depression or otherwise, it's a good idea to do this collaborative care, because the patient wouldn't tell, he would have stopped the medicines, and you would perhaps not know at all whether he needs to continue the medicines or not. So that consultation is useful to whether he should be restarted on those older medicines or you have to give something else. And psychiatrists would also know what are the drugs which this person has in the past tolerated. So that's another benefit that you will get if there is a old history of a psychiatric illness in this given individual. And of course, if the present interventions, what you have done, SSRIs, you have given 50 mg of sertraline, and you have done some counseling, explained the individual, explained the family, but still something is going on and is not getting better. And so you are also not able to increase sertraline from 50 mg to 100 mg. For various reasons, you are worried, and you suddenly identify the drug interaction with the drug that you are giving. Today, all of us have forgotten to teach in the classrooms the drug interactions, because students know more about drug interactions. Patients know even more. They check the Googles and so on and so forth, and then they know what the side effects, which drug or which causes, which should be taken or should not be taken. But nonetheless, when you know that you cannot afford to increase the medicine for this individual, what else we can do for this individual? Suicide risk being very high, again, do you have to do something else? You want to give treatment other than just the medicines. is a consultation that would help with the psychiatrist. And of course, when the medical condition is still significant, you would have otherwise, if you had gotten better, you would have discharged when the medical condition was stabilized to go to a psychiatrist. The psychiatric condition is very significant, but the medical condition is also significant that you can't discharge the patient. So at this time, of course, it's a good idea to call the patient, call the psychiatrist to help you out. So I'll summarize. It is commoner in medical ill than we all thought. It is often underreported by the patient, asked by us as well. So keep a watch, 2 or 3 questions. There are, of course, several instruments that are available to detect depression. I'm not going into those theoretical things. Simple thing, how are you? How is your mood? How are you feeling? How lively you are? How are you able to attend to your family course? How are you able to attend leisure activities? Do you enjoy the same TV program, the newspaper, or the stories? Enjoy playing with your family members? A lot of what we may see as common sense questions which elicit also depression. If you don't treat, there are some adverse consequences which I have already mentioned. Chronic medical illnesses and depression share some common factors which includes lifestyle. Please ensure that the lifestyle is made as healthier as possible for this individual. Diagnosis of depression is possible with a known constellation of symptoms. The slides are here, so if you want to use it, you can use it. There are treatment options from non-medicine related treatment to medicine related treatments, and of course something beyond the medicines as well, what we may call as the electroconvulsive therapy. Non-medicine treatment include lifestyle advice, counseling, emphasizing some of the yoga practices which he can afford, and of course medicines, I said SSRIs, mirtazapine and bupropion. And always consider the non-drug treatments as the first line. Unless the condition is so severe, you have to call a psychiatrist. He or she may think of an alternative treatment. That is drugs. So I'll stop here. I bow to Ma Saraswati for blessing me with all this wisdom to share with you. And I also am working in this yoga center as the Professor Emeritus of Integrative Medicine at NIMHANS at this point of time. Because most often my introduction was I am the commission chairman of NMC, but NMC activity is a non-academic activity, but this is an academic activity. I thank each one of you for being there, and I'm sure you're all very hungry, if not angry, but Dr. Gupta ji has made a big feast for you. Thank you. This is my email. If there are anything that you want to share with me, I'll be happy to respond to you later on. Thank you so much.
Thank you, sir, for this informative presentation. It was incredibly insightful and helpful. Now, I would like to welcome Dr. Manoj Kumar Sundarka, clinician and environmentalist from England, UK, to present on topic Global Warming and Health, an abridged overview. Please give a huge round of applause for Dr. Manoj Kumar.
Welcome everyone. I am Dr. Manoj. I am working as a clinician and environmentalist in Medway, England. And here, just to give this different topic of touch, which is slightly other than the hardcore medicine, and I believe that will be working as a buffer in the midst of hardcore medicine. Why I have chosen this subject? The problem is, one day, I was listening to that greenhouse gases, and I'm sharing my experience. I was thinking, if this is green, then why it is disastrous? Thereafter, I thought, why not to explore the subject, go through the terminologies which are differently used: carbon credit, global warming, climate change, a lot of things. And especially it was discussed in our G20 summit. So I explore this. So this is my subject of interest at the moment. Just watch this video. We started from here. Glaciers are melting due to global warming. Rapid exhaustion of industrial exhaust. Sorry, just back again, just back. Sorry, the video again. Oh. There is no sound in the video. This we are achieving at the moment. Ice caps are melting at the poles, industrial exhaust. This is the surface you can see from, if you go in the sky from the plane. Our land is looking like this. There are the wildfires, droughts everywhere, and design is changing. Greeneries are going off. From the ocean, you can see the tired polar bear of seeing the human-made disaster. And this is the current interesting thing. These are the wildfires. From where we started and where we went. Now you can see, this is the situation of Delhi. So what is this global warming mean? The world heats up in response to the accumulation of carbon dioxide and other greenhouse gases in the atmosphere. And since the Industrial Revolution, about 170 years ago, we have reached 1 degree extra Celsius we have added in our climate. But since last 40 years only, the rate of rising temperature per decade has doubled. And climate scientists are really worried about it. And they have now put a target by 2040, we should limit the global temperature rise to 1.5 degrees Celsius only. Now see this change. Over those 110 or 20 years, that blue graph was there. And now in this last 40 years, this red angry looking graph, and we don't know what will happen in next 10 to 20 years, might be the black graph. So the concept of greenhouse gases, what does it mean? Certain gases prevent the heat from escaping our environment, atmosphere, by absorbing the radiation, thus keeping our planet warm. These gases include carbon dioxide, methane, nitrous oxide, and these are collectively known as greenhouse gases. A carbon footprint is made out of these greenhouse gases, but because the chief component here, you can see carbon dioxide is there, and because the carbon is the hardcore of that, for practical discussion, we discuss like a carbon footprint, although that's representative of everything. And mind it, this footprint is not like it's a print of my foot and shoes. This is what activity you are doing and how much carbon you are producing and adding to the climate. There is a unit for that. So what is the carbon cycle and the CO2 movement? This is a natural system of recycling carbon atoms through the plants, animals, underground material, minerals, and atmosphere. This is a cycle. Our planet is considered as a closed system. It is neither losing or neither gaining the carbon. And so where is the carbon? Carbon is mainly stored at places where the carbon is in atmosphere, such as rocks, sediments, living organisms, and ocean. This is a cycle. Consists of like photosynthesis, decomposition, respiration, and finally fuel combustion. This is worth noting, as we commonly know that plant is taking carbon dioxide and giving us oxygen. Before writing this article, even my concept was this, but when I digged it out, I found out when there is no sun, even plants are adding carbon dioxide to the climate as well. So it is important that we should be planting more and more green plants. During the sun time, they can take the more and more carbon to balance the situation. Here is the cycle. You can start from anywhere, and you can see all the factors are causing increase in carbon dioxide in the atmosphere, and which is dissolved in the water can reduce the pH of the water, and that's a disaster. Only one process, that's the photosynthesis, can take it back, so this is only balance it. There are 100 factors which are adding, but only one factor which can reverse it. So we should focus on more plantation. Now, what is carbon footprint? When this word came to me, this was very exciting to me. A carbon footprint is not made by one's foot, as I said, but by one's action. A carbon footprint can be calculated by summing up all the activities, what we do, all the actions or activity has to be performed, that we have to sum it all, that how much carbon has been produced and gone to the climate. Just for an example, if we consider a house built on 200-meter square land, a 3-bedroom bedded house, and fill that house with the carbon dioxide fully, that will count as a one unit of carbon footprint. Other example could be, as the smartphone era, if you are charging full a smartphone, like 120,000 smartphone, you are adding 1 unit of the carbon to the climate. Or if you are doing some activity where 500 liters of diesel consumption is there, that will add to the 1 carbon footprint. Globally, the average annual carbon footprint per person is nearly 4 tons at the moment. And our target is to, by 2050, we should reduce it by half, so 2 tons. That's a big target, and how we will possibly achieve it, we all are responsible to act towards. Otherwise, we will just pass a risky climate to our further generation, for which you are working today and accumulating. What is the impact on health of this situation? As I said, it's away from this subject is away from the medicine. No, it is interlinking, because we are producing carbon as well, and we will suffer as well. So health professional cannot be isolated from this. Like exposure to the climate-related health hazards include biological, chemical, physical stressors, or differ in time, location, population, and severity. Over the past 2 decades, death caused by modern forms of pollution have increased by 66%. This was really a reference to an article in 2022 in Lancet. Nowadays, most human activity requires electricity. Nobody can deny that. So what to do? We need electricity. Suppose for 5 minutes our electricity goes here, everybody will feel like a paralyzed. But we need electricity, so what we should work on, we should venture more and more clean electricity methods. Like those could be solar, wind, waves, or hydro renewable electricity production. And I'm very happy to say, just few months ago I was watching a video, India is at the moment top in the list to produce solar power related electricity. That's achievement. Look at this. This is important to us regarding the health hazards. This rapid rise in the concentration of greenhouse gases leading to rising atmospheric temperature and reduce the pH of the water. That's the main consequence. That disturbing the plant and animal growth. Clinical, climatic catastrophe and extreme weather events like storms, tsunamis you can get. Oceans are getting warmer, getting the different biodiversity and the organisms which are living in the ocean. Poor air quality, we have lots of cardiovascular and respiratory diseases. Reduced food and water security, surge in the acute and chronic diseases, extreme weather events, and social impact and the mental stress. You can see this COVID pandemic, it might be due to the climate change, that the virus which was not disturbing us for last 3 or 4 decades disturbed us, and the whole world stopped for 1 year. And that was giving so many increase in the depression and mental illness as well during COVID epidemics. So these are the factors impacting our health and all system of our health. So this much is the burden. Is there any role? How we will going to counter it? Again, I think I said, this changes and things and responsibility is at every level, like individual, our institution, nation, and global forces. So how we can do that? At individual level, simply to minimize luxury, reducing the consumption of fossil fuels, recycling the items, sharing the transport, organizing a small educational groups, and share what this problem is, and pay to awareness. At the organizational level, there are basically 2 things which can be very helpful. Like because this carbon is going in the climate, what we can do, either whatever is the mix there, we can just retrieve from there and hold it. The second method can be, we should put an interface, not allowing carbon dioxide to be mixed in the climate. Just before the factory exhaust, we should stop it. But those two methods are known as carbon storage and utilization and direct air capture. I will mention later on. There was a common consensus signed by 195 nations in 2015, and now the whole globe is worried about this problem. What is the role of health professional? Just now the GMC in the UK and NHS and RCP, Royal College, have come with the clear guidelines that these are the responsibility of the health professional. If you could do, we can reduce the carbon addition, like practice evidence-based medicine, prescribe wisely, promote sustainable transport, and adopt hybrid consultation model. And this is a good example. This conference is a hybrid conference as well. That is saving the carbon, adding to the climate. Now, these two techniques I mentioned about CCDUS and that technology. So here the catch is, if we have stored the carbon, we hold it. What to do further? It will need a further step that it can be injected back into the emptied oil and petrol natural reservoirs where the carbon cannot come back to the environment. That we can do. And the alternative approach can be, we can utilize this carbon, change in the format, like the calcium carbonates and things, and that can be utilized, mineral utilization in the road forming, transport, and in building formings and things. That's a way to absorb and keep this carbon return, that it should not go back to the environment. What are the targets? These are the following targets you can see. Just the top one you can remember. The current annual global CO2 emission stands about 40 gigatons annually. And our target is to reduce at least 10 gigatons every year to achieve the target that by 2050, that the overall carbon production to be per person 2 tons, which is at the moment 4 tons. There are few terms you will see in the medias: carbon neutrality, carbon offsetting, net zero, net balancing, and green colonialization. What is carbon neutrality? It is just a balance it. Like how much carbon an individual or country or industry is adding to the climate, is it taking back that much of the carbon by some means? So there is a way of, by investing in carbon offset projects, like here suppose in Delhi heavy industrialization is there, and we can't do anything about it. We are investing money in Africa where the green land is there, paying $20 per in the greenland farming, and then give us a 1 carbon credit, and we are balancing that. Somewhere we are producing more, somewhere we are utilizing, and a cycle and balance it can be maintained at the moment. 1 carbon credit typically represents the removal of 1 metric ton of carbon dioxide, as I said. The concept have evolved in official net zero, but mind it, this is not we are reducing the carbon, we are just making balancing across the globe. So some interesting point, this plant-based diet and versus the non-vegetarian diet. It has been seen to feed the population of about 8 billions, we need about 38% of the land mass to grow the food for them. If we go on the vegetarian diet, we need only 7% of the land mass, and we are saving 31% of the land mass of the world. And you can see, we will not need any maintenance of that land mass, and there will be a huge reduction of carbon dioxide. So these are the few targets. And you can remember these 3 golden words to combat this situation, like our very hit film from the South India, RRR. Reduce, reuse, recycle. Reduce, reuse, recycle. And here every individual is responsible for their consumption and should be willing to change. It's not only the government's duty to do that. These are the few summary points, as I said. Carbon dioxide plays a vital role in our atmosphere by regulating the Earth's temperature. The rapid accumulation of CO2 is causing global warming, leading to the climatic catastrophe and the health hazards. Every individual and organization and country are responsible. and switching to renewable energy sources are very welcoming facts, and green plantation. And the goal should be achieving zero emission. We should not be just settling for the what we call net zero, which is happening at the time. Thank you very much. Yes, please.
Thank you, sir, for sharing your insights. Now I'd like to welcome Dr. Archana Sundarka, consultant OBS Gynae from St. George's Hospital, London, on her topic, single-dose pre-pregnancy intralipid infusion in recurrent pregnancy loss. Please welcome with a great round of applause.
Good afternoon, everyone. I am Dr. Archana, consultant gynecologist. My work is based on intralipid in cases of recurrent miscarriage that I have worked in my clinic at Delhi. Previously, I worked in NHS St. George's, and now I am based in Delhi. Everyone knows how devastating miscarriage is in women's life. If pregnancy is lost before 24 weeks, that is called miscarriage. And if it is happening again and again, that is called recurrent miscarriage. Whenever a couple comes with positive pregnancy test, we know how happy they are, and that is the moment of celebration for them. And suppose that pregnancy is lost, they become sad, they seek help of doctor, and when they come to gynecologist, we don't have anything to help them. That time pregnancy is already lost. We say, okay, go and try again, you will conceive again, and nothing will happen again. Again they conceive, and sometimes they miscarry again. Then the disaster happens. They come to the gynecologist. We say few words, send them again, and we run few tests, and they are also helpless. We don't have any definitive treatment at moment. Slide is not running. Is it not moving? At moment, the incidence of miscarriage is 10 to 50% of women of reproductive age, and out of them, 1% is recurrent miscarriage. How much they are impacting the lady's life? First thing is emotional. They are emotionally depressed, sad. Family is also depressed. Financial, they have to undergo dilatation and evacuation. Social burden, sometimes their married life is at threat. Husband saying that divorce is impending. So there is no available treatment at present. Can be a traumatic experience, undergoing dilatation and evacuation, leading to excessive bleeding. They have to undergo blood transfusion. Curettage gives rise to synechia formation, infertility later on. My work is based on recurrent miscarriage. It's not going, not moving. Yeah, no. Okay, so now there are what are the causes of recurrent miscarriage? Chromosomal abnormalities is said to be most common cause, and that is also for sporadic miscarriage, one-off. They will not have again and again. Antiphospholipid syndrome, SLE, hormonal imbalance, such as uncontrolled diabetes mellitus, hypothyroidism, uterine malformation, septate uterus, etc. My work is based on immunological, where there are a high number of natural killer cells attacking the embryos. What happens? That pregnancy contains paternal DNA as well. Womb lining, endometrium, attacks them thinking that they are foreigner to us. So I have worked on this cause of miscarriage. What are the investigations available? When they come with history of recurrent miscarriage, we advise them to undergo few investigations like ultrasound, hormonal profile test, some blood tests to diagnose antiphospholipid syndrome, chromosomal genetic testing. Sorry for the inconvenience. And sometimes we have to do chromosomal analysis of the RPOC as well. Yeah. Investigations, they have to undergo. We advise ultrasonography, chromosomal and test, hormonal test, karyotyping of both partners, karyotyping of product of conception, thrombophilia screening, that is also very cumbersome and very costly test, natural killer cells test in the blood and endometrium. In the blood, it is also not very sensitive and specific test. Endometrium, you have to test for natural killer cell. Then you have to take endometrial biopsy. Not very easy to the patient. Usually they come to us after exhausting all their money and energy and hopes. So at present, what we are offering, aspirin, low molecular weight heparin, corticosteroids, progestogens, Intralipid in IVF setting. At present, Intralipid is being given in IVF settings only, where they are giving 3 doses of Intralipid pre-implantation, after implantation, and when first pregnancy test positive comes. And LIT is another mode of therapy, genetic screening, IVIG, intravenous immunoglobulin, that is also very expensive test. And sometimes we don't have anything just to support her. My work is based on Intralipid. So how it all started? In December 2019, I had a patient, 33-year-old. She was nulliparous, no issue. She had history of 3 miscarriages. She had exhausted all her finances, all her energy. She came to me emotionally depressed, hopeless, and she said, everything was done in the last pregnancy. Doctor, if you have something to offer me, please advise. And so that gave me a brainstorming challenge. I started researching literature, podcasts, YouTubes, and all the journals. And I heard they mentioned about Intralipid. a fat emulsion that can be given intravenously, and that gives rise to high success rate. I found this literature in a paper of Center of Human Reproduction, and they give intralipid in IVF setting. Until now, the therapy is being used in large-scale IVF center in cases of recurrent implantation failure. I thought, why not is going to help my patient? First, I counseled the patient. I asked any side effect, any reaction, I advised her. And she got ready to get this therapy. In 2019 December, I gave her intralipid therapy. I was very scared that time. Will there be any reaction, adverse reaction, any teratogenic effect? And with all uncertainty, I kept all the emergency medicine with me. I administered her intralipid, and next 4 weeks, she conveyed me that I have got positive pregnancy test. I thought, okay, we will do ultrasound after 6 weeks. That has also positive indication. Fetal heartbeat was detected. After 7 weeks, ultrasound was okay, and 12 weeks ultrasound was also normal. She delivered at 9 months live birth, successful live birth. That gave me a boost, game changer, and that encouraged me. I started giving intralipid to all the patients who ever coming to me for recurrent miscarriage, where all the other causes of miscarriage was excluded. So so far, I have given intralipid to 74 patients. Out of them, 40 conceived within 8 weeks, live births in 39, ongoing pregnancies 4, miscarriages 1, miscarriage happened in 1, and rest of them, they are not responding, and someone, they didn't conceive. My study was affected by COVID as well, because 2021, I could not give to many patients. So question is, what are intralipids? Well known to our medical faculties. For me, it was a new medicine, so I studied a lot. Intralipids are intravenous lipid emulsion, invented in 1962. It is made up of soya milk, egg protein, egg white, glycerin, and water. It includes linoleic, alpha-linoleic acid. And so far, where intralipids being used, it is used in total parenteral nutrition, where patients can eat and drink in terminally ill patients. And another use is toxicity of local anesthetics. It is a life-saving medicine for local anesthesia toxicity. And in IVF setting, in recurrent implantation failure. Next question is, how do we administer? Usually it is available in 100 ml of bottle. I am diluting it in 300 ml of saline, making it total 400 ml, and administrating very slowly in 4 hours. Usually I am giving single dose, and it is very cost effective. One bottle of intralipid is available in around 300 rupees in India. Prior consent, usually I take. All the side effects I explain to the patient. History of allergy, egg yolk, soya was taken because it is made up of soya and egg yolk. So what are the different contraindications? These are the contraindications where it should not be given. How does it work? Usually it is effective in immunological miscarriages, where there is hyperactivity of natural killer cells, and it works through the mediator of inflammatory cells. So nut cell intralipids deactivates natural killer cells in women's body. Recently, one of my patients delivered after 9 months of pregnancy. She had 5 miscarriages. She was hopeless. Last year, November, she came to me for consultation. Doctor, do we have any treatment for miscarriage? Because last 5 pregnancies, I have tried everything. I have been seen by many gynecologists and nothing is working. Should I try another pregnancy or should I go for IVF? I said, wait, I will give you Intralipid, you will see the result. And luckily she conceived in the same cycle when I gave Intralipid and she delivered recently. Please see the video. Sound is not coming? Video sound? Sorry. So the lady has given me testimonial video. Sound. Sound is not coming of the video.
हेलो, मैं राधिका शर्मा दिल्ली से। मेरी शादी को 5 साल हो गए थे। मुझे मल्टीपल मिसकैरेज का इशू था। फिर मैंने बीजी क्लिनिक विजिट किया, जहाँ पे डॉक्टर अर्चना मैम ने मुझे इंट्रालिपिड के लिए सजेस्ट किया। फर्स्ट साइकिल, फर्स्ट डोज में ही मैंने बेबी को कंसीव।
I'm very sorry for that. I have recorded the sound as well.
हेलो, मैं राधिका शर्मा दिल्ली से। मेरी शादी को 5 साल ने मुझे इंट्रालिपिड फर्स्ट डोज में ही मैंने बेबी को कंसीव कर लिया और आफ्टर 9 मंथ्स मेरी सक्सेसफुल डिलीवरी।
Okay, this is my another patient who had also conceived after Intralipid therapy and she had a baby 1 year ago. She was also very happy after
हेलो,
the
मैं
baby.
राधिका शर्मा दिल्ली से। मेरी शादी को 5 साल हो गए थे। मुझे मल्टीपल मिसकैरेज का
Okay,
इशू था।
subtitle is there, okay. So I will conclude my talk. In our part of the world, many patients do not have access to basic health care. They can't undergo sophisticated investigations. Treatment options are beyond their reach. Intralipid therapy is extremely cost-effective approach. Additionally, it has got no side effect, is very easy to administer. Compliance is also high. We have seen very encouraging results. To further validate our results, multicentric trials should be done and it should be given to more and more patients so we can have better results and better data. Acknowledgement and references mainly taken from Royal College of Green Top Guideline. And special thanks for audience for listening. Any critical analysis or feedback? Because this is my own study, I want in feedback. Any question? Okay, thank you.
Mitochondrial DNA. So that has got roughly around 37 genes. And very importantly, mitochondria, we call them as a power station of human body, redox generation. That means adequate amount of oxidative species are generated in the mitochondria and they remain inside the mitochondria. Because if they leak outside, there will be irregular apoptosis or cellular death. So it regulates the apoptosis and it is a key regulator of glucose-stimulated insulin secretion. So over the past years, past decades, evidence has been accumulating that mitochondrial function is closely linked to the right from the inception of metabolic syndrome, pre-diabetes, diabetes complications, progression of complications, and end stage of complications. So mitochondria dysfunction is the root cause of all these things. So now just remembering how our food which we consume is being utilized. Glycolysis is the process that occurs outside the mitochondria, that is in the cytosol. Glycolysis is happening, end product is pyruvate, whereas fatty acid oxidation or beta oxidation that happens inside the mitochondria. Both of these two lead to one thing, that is acetyl coenzyme A and pyruvate. They go towards TCA cycle, and that happens inside the mitochondria. This TCA cycle leads to production of two electron donors. One is NADH2 and another is FADH2. So these are the two important electron donors. I have digged out these terms from our biochemistry classes, but these are very important. So these are the fuels for mitochondria. ATP production, there has to be fuels. Carbohydrates provides pyruvate, fats provide free fatty acids and acetyl coenzyme A, proteins as a source of amino acids, lactate and ketones. These are the sources of ATP production. Now there is another thing that is known as mitochondrial dynamics. They are not sitting alone. They are doing lot of work. There is lot of fission, fusion and mitophagy. And what do we mean by fission and fusion? Fusion is when two mitochondria combine together and they exchange their material and they become a super complex formation. So whenever there is need, you will have these super complex formation. Fission is when damaged mitochondria, they are excised from their healthy mitochondria and they are degraded by lysosome. We call them as a mitophagy. What is driving these fusion and fission? Fusion is triggered by decreased amount of ATP availability, yani energy demand chahiye. Increase ATP demand, then there will be fusion. Whereas fission is triggered excess substrate availability like glucotoxicity, lipotoxicity, overfeeding, increased oxidative stress, chronic inflammation, infection, all these will lead to mitochondrial DNA damage. This is another thing which is important to understand the concept. Electron transport chain or oxidative phosphorylation or cellular respiration. There are 5 complexes, complex 1, 2, 3, 4, 5. These are the complexes which exchange their electron. And electron donors are 2, NADH and FADH. They give electron to complex 1 passes to complex 2, 3, 4, 5, and then up to 5. 5 has got ATP synthetase. It is uncoupling protein which leads to ATP synthetase. And there is once electron is being passed, H ions are produced and they are shifted to the intermembranal space. This electrochemical gradient is extremely important for this electron transport chain. So this is very easy to understand. So mitochondria, each and every corner of mitochondria is functioning very importantly. Cytochrome C leads to capsase activation, there is cellular death, H2O2 protein thiol oxidation, gene expression is implicated, AMPK pathway, again catabolic switch, mitochondrial DNA itself lead to inflammation, regulation of inflammation, TCA cycle, cell fate and function is decided by this TCA cycle. Now, what causes pathogenesis of mitochondrial dysfunction? Kaise ho gaya? It happens due to many things. There can be genetic mutation of mitochondrial DNA or a nuclear DNA that leads to damage to the mitochondria. Aging itself can lead to mitochondrial dysfunction, sedentary lifestyle which is rampant in our society nowadays, infection and chronic inflammatory stages. So this is normal mitochondria having excellently working electron transport chain, proper amount of redox rate, our reactive oxygen species are nicely produced, calcium homeostasis is produced, balanced redox potential, balanced apoptosis, these are greener mitochondria. Whereas there is abnormal oxidative phosphorylation chain, excess amount of reactive oxygen species produced, lot of oxidative stress, there is lot of calcium overload, abnormal cell apoptosis and cellular death and injury. What are the diseases which you can implement here? Name any disease. The root cause is mitochondrial dysfunction. Right from your type 2 diabetes, Parkinson's disease, Alzheimer's disease, your aging, cancer and everything, leads to underlying defect is at the level of mitochondria. So you call them mitochondrial dysfunction? Yes. Now how diabetes is related to it? Diabetes is related to it directly and indirectly both. There is bidirectional relationship. Mitochondrial dysfunction is indicated as there is decreased mitochondrial content, there is altered bioenergetics, there is altered biogenesis, leading to beta cell secretory defect leading to insulin resistance, and there is more damage to the beta cells. So, and then this lead to complications and worsening of complication, further increasing hyperglycemia, further increasing glucotoxicity, lipotoxicity, further leading to mitochondrial dysfunction. So remember this, our old triumvirate hypothesis of impaired insulin secretion at the beta cells of pancreas, peripheral resistance at the level of muscle, and central resistance at the level of liver, leading to hyperglycemia. But now we know that it is ominous octet and ever-expanding list of these pathogenetic mechanisms. Now coming to the basic, mitochondrial dysfunction, how it impairs insulin secretion. We all remember insulin secretion is ATP dependent. Potassium ATP channel को close होना पड़ेगा, calcium it has to enter inside through the voltage gated channel, and then insulin will be secreted. So mitochondrial dysfunction leads to decreased ATP production in the beta cells of pancreas, and there is decreased insulin secretion due to decreased NAD and decreased calcium in the cell, in the beta cells. Now, mitochondrial dysfunction also leads to insulin resistance, decreased glucose uptake at the level of liver and at the level of skeletal muscle. There is decreased GLUT4, which are the transporter for glucose entry into the cell, decreased tyrosine phosphorylation, and increased serine phosphorylation. So serine goes up, tyrosine is impaired. Decreased AKT phosphorylation, and there is decreased PPAR gamma complex 1 alpha activity. All these lead to three things. There is LCAC increase, that is long chain acyl carnitine, diacyl glycerol, and ceramides. They are leading to increased amount of insulin resistance at the level of muscle and at the level of liver. So this is normal cell having appropriately functioning complex 1 giving electron to complex 2, 3. So this is an appropriate way, and there is less amount of reverse electron transportation. But what happens in a diabetic cell, complex 1 is hyper functioning. Yani ki you are driving your car in just first gear and pushing on the escalator button, pushing on the escalator pedal. What will happen? It will ignite lot of fumes and lot of heat will be generated, and that happens. Complex 1 is hyperactive, complex 2 and 3 are down regulated. So there will be lot of reverse electron transport from 2, 3 to back to 1, leading to more amount of reactive oxygen species production, and they lead to opening of these pores which are there in the mitochondria, and these reactive oxygen species just leak from mitochondria inside the cellular matrix and leading to cellular damage. So you can have hyperglycemia, you can have lipotoxicity, leading to mitochondrial dysfunction and biogenesis, and they lead to abnormal liver and muscle steatosis, lead to insulin resistance, defective glucose-stimulated insulin secretion at beta cells of pancreas, leading to micro and macro cell complications. So how can we reverse mitochondrial dysfunction? There are so many modalities, and we are doing it. We are doing it. Only thing, we are not focusing on mitochondrial dysfunction. So the first thing to remember, mitochondrial dysfunction or the boosters for mitochondrial dysfunction is your exercise. Aerobic exercise, anaerobic exercises, stretching exercises, flexibility exercises, all these are extremely important for having your greener mitochondria. Exercise improves the overall mitochondrial biogenesis, decreases reactive oxygen species, improves electron transport chain, increases level of coenzyme Q10, and improves fatty acid oxidation. Also, this exercise leads to insulin improvement in insulin secretion and insulin action also. Now coming to antioxidant, there have been so many literature for antioxidant, maybe coenzyme Q10 supplementation, vitamin E supplementation, omega-3 fatty acid supplementation, but most of these are in phase 1, phase 2 trials, and they are not being replicated in phase 3 trials. We don't know exact route of these administration, how to give them, whether IV or oral, not knowing exact dosage for these antioxidants. But things are now improving. Vitamin E is coming back again in certain subset of patients like hepatoglobin 22 gene polymorphism. They have got a lot of oxidative stress, and their vitamin E is working. And also you know that NAFLD patient, they do respond to vitamin E. Now coming to metformin, our age-old friend and the backbone of treatment of type 2 diabetes. Metformin basically decreases complex 1 and it inhibits complex 1. It reduces reactive oxygen species formation, activates AMP kinase pathway, and favors mitochondrial biogenesis through phosphorylation of PGC1 alpha by AMP kinase pathway. So metformin has got definite effect through the, in improving mitochondrial dysfunction. Then again, pioglitazone, our friends, they do have these benefits, decreasing oxidative stress, decreasing inflammation, improving mitochondrial biogenesis, and improving mitochondrial dynamics also. SGLT2 inhibitors, they do these things at the root level. They improve fusion of mitochondria. They improve mitochondrial replication. Also improve mitochondrial quality and functionality. Improves ATP production at the level of mitochondria. And improves insulin sensitivity by decreasing insulin resistance. Now this is the molecule which is still, I must say, that is in infancy, but we are using this molecule because of their, again, good number of benefits. It has got two important effects. One effect is it improves the beta cell function and beta cell protection also. And another is it improves insulin action at the level of liver and muscle. It basically, it inhibits complex 1, but partial inhibition, not like metformin. Again, it improves complex 2 and improves complex 3 also. So it decreases reverse electron transport chain. And this molecule, this is how it works, and ultimately it leads to better beta cell function and survival also. So beta cell mass will also improve. And it has got beyond glucose lowering related effect also, pleiotropic effect on improvement of endothelial function and improvement of diastolic dysfunction also. So we have got literature, data showing imiglamin has good effect on even release of insulin. 110% phase 1 insulin secretion improves. 29% increase in phase 2 phase of insulin secretion. Then improves beta cell glucose sensitivity by 36%. And if the chronic use of imiglamin is there, it improves beta cell mass, beta cell proliferation, and suppresses beta cell apoptosis. So the literature is building for this molecule. Probably you can have more and more molecules from this class of glimmin class of molecules. So literature is also showing that it has got salutary effect on non-alcoholic fatty liver disease also. It improves skeletal muscle functionality, just like your exercise mimetics. Also, it has got improvement in endothelial dysfunction and improvement in left ventricular function, specifically left ventricular mass index, and improves renal function. But they are all in smaller and smaller phase 3 trials, and also many mechanistic and rat models. But we do want long-term trials, CVOT trials, and renal outcome trials also. And these are for cardioprotection, and importantly, left ventricular mass index improves, so that has got salutary effect on diastolic dysfunction. So how it is different from metformin? Actually, metformin totally inhibits complex 1, where this molecule partially inhibits complex 1, and that, again, metformin leads to decrease in glycerol phosphate dehydrogenase shunt. That means there is increased propensity towards lactate formation, and due to, in many cases, like in those patients who are having hypotension, who are having organ dysfunction, then you are worried about lactate dysfunction, in hyperlactatemia in patients with on metformin use, where this cannot be there in imiglamin. So this molecule is an excellent molecule we are using for the past 1.5 years, and we have seen the results are coming up. But the whole vista of improvement in mitochondrial dysfunction and focusing on the root cause of non-communicable disease is opening up, and we are having more and more agents which are coming up which will be having the target on improvement in mitochondrial dysfunction at the root level. There can be antioxidants which are targeting specifically mitochondria. There are PPAR agonists also coming up, and AMP activators also coming up. Serotonin activating compounds are also coming up, and decreasing or inhibiting mitochondrial permeability transition pores are also coming up. So the carry home messages from my talk is, quantitative and qualitative abnormalities of mitochondria are recognized in the pathophysiology of diabetes. Mitochondrial reactive oxygen species play a major role in perpetuating hyperglycemia and its complications. Targeting mitochondrial physiology at different level is an exciting era of therapeutics. Currently, very few drugs we are having. Targeted antioxidant therapy is coming up, and the class that is glimmin class, or imiglamin, the novel molecule from Japan, this has got definite mechanism targeting mitochondrial dysfunction at the root level. And this molecule has got definite benefits and promising drug class in development. Thank you for the patient listening. We can have interactions if you want to have. I know this was somewhat more of biochemistry, may not be interesting, but this is the time to revise these things. Because newer and newer molecules are coming up, you will not be able to chase them until unless you know the basics. So don't try to forget basics. These are very, very important. If you look at the basics, you will be having more options for your patients. Yes, please. Okay. So presently there is no data for type 1 diabetes, but I have not used it. And we require definitely, type 1 diabetes is a very different setup, just like pregnancy and lactation. We don't have trials for type 1 diabetes. Only we depend upon insulin and insulin pumps. But this is the molecule which per se don't lead to any hypoglycemia. But yes, I may be wishing to use this molecule in obese type 1 diabetic patient. But friends, this molecule can be used with metformin. This molecule can be used with many all oral anti-diabetic drugs with insulins also. So there are trials which I have missed, times 1, times 2, times 3 trials. And there is PRISM trial, all pan-India that is going on, and we are going to have this data in next year. And this molecule is definitely effective. Yes, sir. So there is a subset of patients who have post-prandial sugar normal still and they get fasting plasma or fasting blood sugars are still high. Yes. Sugar is normal. Yes.
We don't have much molecules for such
target.
Yes.
Yes.
Patients.
Definitely.
So this could be the one breakthrough in such molecule, number one. Number two, what is the lowest EGFR where this subset of drugs can?
Okay, sir. Fine. So this is the molecule which targets fasting plasma glucose and it decreases hepatic glucose output, the prime effect. So this molecule is definitely indicated when you are struggling with uncontrolled fasting plasma glucose in your patients. You have got many medication for postprandial hyperglycemia, but there is no specific medication, only basal insulin comes to your rescue for management of fasting plasma glucose. And this is the molecule which can be put into your treatment paradigm for management of fasting plasma glucose. Yes, in pre-diabetic patients which are having fasting plasma glucose of 120 to 126, that means they are just near to crossing 126 and they have got strong family history, they are obese patient, they will going towards diabetes within next 2-3 months and 6 months. आने वाली दिवाली पे उनको diabetes हो जाएगी. So this is the time to start this molecule. Convince them that this is the molecule to prevent further conversion. We don't have data, but yes, theoretically you can use this molecule as we are using metformin. This is much safer than in comparison to metformin. Yes, we have got DPP trial, Diabetes Prevention Program trial with the metformin where 31% decrease was there in conversion from GDM patients to diabetes or pre-diabetes to diabetes. That was there, but we don't have trial with imiglamin, but still you can use this molecule. Up to eGFR 30 mils per minute, it is recommended from DCGI, but Japanese guidelines say you can go even up to 15 mils per minute, where you are not able to give metformin. So metformin we don't give below 30, okay. From 45 to 30, you have to decrease metformin dose by half, and below 30, you have to omit metformin. Whereas this molecule can be given even up to 15 mils per minute eGFR. Thank you. Thank you.
Thank you for your excellent performance, sir. To all those delegates who attended BLS workshop, please collect your certificates from the registration counter. Now I'd like to call upon Dr. Neeraj Singla, MD, DM, Fortis Hospital, Ludhiana, to present his topic, Management of MASLD, NAFLD.
Thank you. Good afternoon, everyone. First of all, I would like to thank the organizers for inviting me for this talk. So I am going to discuss about management of NAFLD or MAFLD. So there has been a recent change in nomenclature from NAFLD, that is non-alcoholic fatty liver disease, to metabolism associated fatty liver disease. So initially the term NAFLD, it was coined by Ludwig to describe fatty liver in patients who were non-alcoholics. So they found similar findings in non-alcoholic patients. Patient had fatty liver, so they labeled it as non-alcoholic fatty liver. So the recent thought process is that the word non amounts to trivializing this issue. The word alcoholic is unjustified. When the patient is not taking alcohol, having name alcohol in that disease is not justified. So the nomenclature has to reflect the new knowledge which has been there from the last 1 decade. So diagnosis should be based on presence of metabolic dysfunction rather than the absence of other conditions. So why we need to discuss this? So this is there is a huge pandemic of MAFLD. If we see the worldwide prevalence, it is 25%. So every 4th individual is suffering from NAFLD. Among diabetics, every 2nd diabetic is having NAFLD. Among children, 8% of the children are affected with NAFLD. If we talk about the next stage, that is the steatohepatitis. So 6 to 7% patients, this population has NAFLD, and among diabetics, every 3rd diabetic individual is having steatohepatitis. So this is a spectrum from non-alcoholic fatty liver, where there is plain steatosis, there is no or very mild inflammation. It can gradually progress to NASH, or the new term is the MASH. So metabolism-associated steatohepatitis, when the inflammation starts to begin. So it leads to damage to the hepatocytes and release of transaminitis. So it can gradually progress to fibrosis, which can be from F1 to F4. F4 fibrosis is basically cirrhosis. So at any point of time from F1 to F4 fibrosis, it can progress to HCC. So that's why it's very important to differentiate plain fatty liver from steatohepatitis, because steatohepatitis can progress to HCC and it can progress to cirrhosis. So when we should suspect fatty liver? When there is a patient in your outpatient who is having overweight, who is obese, BMI more than 23, you should screen for fatty liver. Or if there is a patient who has diabetes, you should always screen for fatty liver. Even in lean or normal weight individuals, if there are risk factors like increased waist circumference, hypertension, dyslipidemia, HbA1c is borderline, or a family history, you should screen such patients. So now how to evaluate a patient who has fatty liver? We should see for other risk factors like diabetes, metabolic risk factors, any family history. We should also take a history of alcohol. Previously it was like NAFLD was labeled for patients who didn't took alcohol. But now it is believed that this new terminology is based on this thing only, that there can be associated damage induced by the alcohol also. We should take a history of alcohol also, because patients with metabolism-associated fatty liver, they are at higher risk than general population if they take alcohol. For evaluation, we need to do liver biochemistry. We should rule out Hep B, Hep C. We should do an autoimmune profile. We should rule out celiac disease, very prevalent in North India. So, and do an ultrasound also to see the liver ecogenicity. So now the question is whether the liver enzymes, they are sufficient to differentiate between simple steatosis versus steatohepatitis. No, they are not. So patients, ALT can be normal in more than 50% of individuals, those who are having NASH. And it can be elevated in 50% individuals who have just fatty liver without any steatohepatitis. So they cannot differentiate between plain steatosis and steatohepatitis. So next is ultrasound. So whether ultrasound can tell us whether patient is having just fatty liver or steatohepatitis or fibrosis. So even ultrasound cannot tell you which stage of disease patient is having. So this is very important to differentiate, because there are selected patients who are at more risk than other patients for progression to steatohepatitis as well as fibrosis of liver, ultimately leading to cirrhosis. So this risk stratification is very important. So how can we differentiate this inflammation and fibrosis? So we have three options. Either we do a liver biopsy, we can have serum biomarkers, or we can do a fibroscan. So if we see, the liver biopsy is an imperfect gold standard. I will discuss about this thing, why it's an imperfect gold standard. So next are serum biomarkers. They are inadequate at this point of time. So why liver biopsy is considered an imperfect gold standard? Because it's invasive, it's painful and expensive. There is poor patient acceptability for liver biopsy. Definitely there is associated morbidity and rarely mortality also. There can be sampling variability between the pathologists, and there can be inter-observer variability also. And it definitely requires an expertise to perform. Coming to the serum biomarkers, the available are, we can see the AST by ALT ratio, which starts increasing. So as there is progression towards cirrhosis, we can see the APRI index, the FIB4, and the NFLD fibrosis score. Now let's discuss about the fibroscan. So whenever we get a fibroscan done, you can see there will be two components in that. The advanced machine have both the CAP score, which is the computed attenuated parameter score, which can tell you about the steatosis. So you can grade the steatosis objectively, whether patient is having S1 steatosis, S2 or S3 steatosis, and it can also tell you about fibrosis. So you can grade fibrosis based from F1 to F4. So F4 is your cirrhosis. But important thing is you should always do it in a fasting state, and patient should not have any active hepatitis, active inflammation, so which can lead to an abnormally high values. So NFLD doesn't just affect the liver, it's a multi-system disorder because it is a metabolic dysfunction. So patients usually have diabetes, patients have obesity, so it affects various organs. There can be associated sarcopenia, CKD, osteoarthritis, coronary artery disease. There is an increased risk of stroke in such patients, skin disorders, polycystic ovarian syndrome, OSA, gallstone disease. So all these diseases can be associated. We need to evaluate the patient accordingly. Coming to the management of NFLD, the most important thing in management is weight loss. So for which you need to counsel your patients regarding diet and exercise. So this is the most important thing in the treatment. Pharmacotherapy I'm going to discuss. So it is required in a selected group of patients. Not everybody needs pharmacotherapy. This includes vitamin E, pioglitazone, saroglitazar. These are the approved drugs. These are the only 3 approved drugs in NASH. So there are upcoming drugs which are already being in use for diabetic patients, including the GLP-1 agonists, liraglutide and semaglutide, and the latest one are the SGLT2 inhibitors. So I'm going to stress a little bit about lifestyle guidelines. So what does the recommendation say? They say that patient should have a 500 to 1000 kilocalories of deficit so that there is a weight loss of half to 1 kg in 1 week. So you should tell your patient specifically to avoid fast food, snacking, and avoid processed food items. They can be suggested about a Mediterranean diet. Regarding weight loss, so the target is to have a weight loss of 7 to 10%. Exercise, tell your patients about aerobic exercise, resistance training. So if you explain them, they're going to understand the importance. Bariatric surgery definitely helps some patients who have a BMI of more than 35 or maybe 40. So why I'm talking about, so what does the guidelines say about weight loss? If somebody loses 3% weight, so he's going to improve his steatosis. At 5% weight loss, so there is benefit in steatohepatitis. There is reduced ballooning, reduced inflammation. At 7%, there is complete resolution of the steatohepatitis. And at 10% weight loss, patient can expect reversal of the fibrosis even. So that's why we tell the patient to have 7 to 10% weight loss. So again, I'm stressing how can we deliver effective lifestyle changes in a real world? Because this is the most important aspect of treatment of NASH. So we can't just tell the patient very vaguely that you lose weight. We have to tell them specific things. We should tell them what this disease is, how it can progress to cirrhosis and even hepatocellular carcinoma. Address the misconceptions that you can't just take it casually. Explain about energy balance. You have to keep a negative energy balance of at least 500 kilocalories a day. Set a smart weight loss target. Tell your patients then when you come for a follow-up after 2 weeks or 4 weeks, you should come with a 1 to 2 kg weight loss. Use appropriate interventions. Tell them about regular meal patterns. Tell them to reduce snacking, portion control, avoiding fast food and night eating. So you can also tell your patients to monitor the calories. There are now apps available. They can use web-based these things also. Also teach them about how to read a nutrition information label. So that is the most important thing. So most of the people don't know how to read the nutrition labels. So whatever they are buying from market, they should know what they're eating. So something to cheer for people who love coffee. Coffee definitely helps in improving the liver health. It reduces fatty liver, reduces hepatitis, and definitely reduces the risk of liver cancer. So as I discussed, so pharmacotherapy, who needs pharmacotherapy? So all the guidelines, the American guidelines, European guidelines, and the Asia Pacific guidelines, they are unanimous in this thing that those who have just fatty liver, those who do not have fibrosis or hepatitis, they do not need any pharmacotherapy. And now is the time for precision medicine. So there are various genes which has been implicated. The most important is the PNPLA gene, and there is another gene TM6SF2 which leads to dyslipidemia. So based on these genes, now there are being molecules, targeted molecules which are being researched so that we can have a tailored therapy so that every person should benefit from that therapy. We can also use an body composition analysis. So this is very important. So especially for patients who have a lean NASH. So they will tell you that I have a normal body weight, then why I'm having a NASH? So if you get a body composition analysis, you will come to know that he might be having a abnormal body composition. He needs to lose fat and he needs to gain some muscle mass. So coming to the pharmacotherapy, the 3 approved drugs are vitamin E, pioglitazone, and saroglitazar. Patients who have associated diabetes, you can consider using metformin, GLP analogs, liraglutide, semaglutide, SGLT2 inhibitors, some role of vitamin D also, and probiotics. And there are other drugs which have been found to inhibit fibrosis. They are in the pipeline. So various drugs act at various pathways. I'm not going to the detail. So vitamin E this was a crucial PIVENS trial. So the dose of vitamin E used is 800 international units per day. It has been found to be helpful in reducing the ALT, AST, and fibrosis also. Regarding tolerability of vitamin E, mostly it has been found to be tolerable. There has been some concerns regarding hemorrhagic stroke risk and increased prostate carcinoma. Pioglitazone, not very favorite among clinicians, usually not tolerated well, leads to weight gain and some bladder cancer risk. And now we have better drugs, so not commonly used. So saroglitazar, again a very good molecule. So it acts on PPR alpha and PPR gamma. So patients who have diabetes, dyslipidemia, they definitely benefit from saroglitazar. So the meta-analysis on saroglitazar says that it significantly improves the liver enzymes, reduces liver stiffness, and improves the metabolic parameters. Liraglutide, which is a GLP-1 agonist, it's an anti-diabetic drug found to reduce fibrosis. Only issue is it is available in injectable form, and it's quite expensive. So the other this analog is the semaglutide, which is now being, you can say, misused in patients who are obese. So it definitely helps in resolution of NASH, still in investigational stage. So obeticholic acid was recently launched few years back with among much fanfare. So definitely the trial suggested that it is quite beneficial, but there was a black box warning for obeticholic acid because above the dose it was causing liver decompensation. And there is very poor tolerability for obeticholic acid because 70% patient report pruritus, which leads to discontinuation of the drug. It also increases the cholesterol and LDL levels. So to summarize my talk, so MAFLD is fat in liver. We have to find whether the patient has associated inflammation or not, and there is associated fibrosis or not. How does it occur? There is excess fat which starts accumulating. There is insulin resistance, oxidative damage, so it's a metabolic dysfunction. How big a problem it is? So it's huge. We need to understand. So it's a second leading cause of transplant in US, and we are not far behind. So who should be screened? Those who have obesity, diabetes, dyslipidemia, patients with hypertension. How to manage? So lifestyle modification. So weight loss is the key. So this is the main treatment. So pharmacotherapy should be reserved for selected group of patients. Thank you. So any questions from the audience? So as I discussed, so it is imperfect gold standard because it's invasive and you are just taking, you can say 0.1% of the liver. So that's why it might not reflect the actual disease. So it is recommended when we do not know most of the time in clinical practice, when we do not know the exact etiology of the disease, to find out the etiology like autoimmune hepatitis, Wilson disease, hematochromatosis. So that's when we try to do a liver biopsy. So just to find out fibrosis, most of the time it is unacceptable for the patients. Yes. So ultrasound cannot differentiate whether your patient is having a plain steatosis or he is having any active inflammation. We need to do either a liver biopsy or we can do a fibroscan to say whether patient is having any steatohepatitis. So ultrasound as well as blood investigation are inadequate to tell you that. We should get a fibroscan done to see active inflammation or steatosis, and we should work up the patient completely regarding diabetes, dyslipidemia, to look for the risk factors. So based on that, we can advise the patient, and we should advise our patient regarding weight loss. So as well as the fat loss basically, to increase the muscle mass. Thank you.
Thank you, sir, for valuable insight during presentation. Now, I'd like to call upon Dr. Preeti Singh Dhot, Professor and Head of the Department of Medicine at AIIMS Bathinda, to share her thoughts on AI, the next revolution in medicine. Are we ready?
Good afternoon, everyone. It is an honor for me to be here today as a part of this prestigious event. I will be talking about artificial intelligence, the next revolution in medicine. Are we ready? So the era of artificial intelligence, machines that combine all human senses, have been depicted extensively in cinemas, from Terminator to The Matrix. Now, what comes to our mind? Is it really dangerous? Is it an asset which we can use to our advantage? Will AI make human doctors redundant? And will humanity always win in the end? So what is artificial intelligence? Artificial intelligence refers to the display of human intelligence by machines. And this term was first coined by John McCarthy in 1956. It is the ability of a machine to think and learn like a human being, and it can play an active role in healthcare, agriculture, e-commerce, and robotics. There are three overlapping concepts in artificial intelligence, that is, artificial intelligence, machine learning, and deep learning. So what is machine learning? Machine learning is something that is supervised or semi-supervised by a programmer. Deep learning is a type of machine learning which acts at a deeper level, inspired by the structure and function of the brain. Deep learning allows a computer program to analyze the problem and come up with a solution on its own, something similar to what a human or animal brain does every second. It is composed of neural networks with the basic unit of the function being called a neuron, and newly created deep learning systems gradually learn, unlearn, and learn. Example is online language translation services that work better with big data. So these were the three components of artificial intelligence, that is artificial intelligence, machine learning, and deep learning. Artificial intelligence came first and occupies the outmost circle. Machine learning occupies the second, and inner circle with DL occupying the innermost circle. Artificial intelligence is a broader term. Machine learning is an approach to achieve artificial intelligence, and deep learning is a technique for implementing machine learning. So these are some of the applications apart from healthcare, like self-driving cars of artificial intelligence, ChatGPT, artificial intelligence, facial recognition, crop monitoring. So application of artificial intelligence in healthcare: disease identification, disease diagnosis, personalized treatment, behavioral modification, drug discovery, drug manufacturing, robotic surgeries, clinical trial research, doing repetitive jobs, and treatment design. So medical chat box can offer relevant, high-quality information, reassurance, answers, and way of thinking about the situation related to human behavior. Artificial intelligence for diabetic retinopathy screening in Africa. Research showing artificial intelligence may help in remote areas, and it has captured Margulis Award. It can analyze a chest X-ray within 20 seconds and can run off a portable phone charger. Developing a dengue model using machine learning, a case study which was done in China. And present uses in Nepal, besides acting the economy and employment, artificial intelligence is optimizing the delivery mechanism of public goods and services, and as has been depicted in this image. So what are the methods which we can employ in healthcare for artificial intelligence? These are telemedicine, online doctor appointments, cloud storage of medical records, health apps. Google and Ethicon are close to perfecting robotic surgeries. 3D printing has personalized artificial implants. Wearables are calculating everything from the number of steps you have walked to your pulse rate. So what next? In China, a smart healthcare strategy as an integral part of artificial intelligence is already functioning in their strategic plan. AI diagnostic tools are permitted by the country's FDA. Chinese Intelligent Medicine Association provides an excellent platform for research, exchange, and cooperation in AI for healthcare. Biomed bet a team of neurophysicians in a televised competition to diagnose brain tumors and predict the expansion of brain hematomas. iFlyTech passed the country's licentiate exam and outperformed 96% of human examinees. In the USA and Canada, Canada has opened the world's first French language school of AI in medicine in Montreal and aims to become a world leader in AI-based healthcare. Apps like Quality Skin can diagnose up to 2,000 different skin disorders merely by analyzing high-resolution images of the affected skin. Doctors analyze and diagnose based on the knowledge accumulated by them over the years. AI utilizes deep learning to analyze and process medical records, clinical findings, treatment protocols, research materials, clinical studies, journal articles, and patient information of multiple patients within a few minutes, something a human mind can never accomplish. What are the benefits? So artificial intelligence devices know which protocol will lead to what outcome in which patient. Better diagnosis and better treatment outcomes. Improved patient satisfaction and reduced incidence of doctor-patient conflicts. Potential to diagnose rare diseases, speed up the process of diagnosis and treatment, reducing the burden on our doctors and thereby increasing their efficacy and productivity. Reduces burden means lesser fatigue, and this translates into enhanced productivity of the healthcare staff and fewer human errors. Healthcare in India, what is the present scenario? India faces an acute shortage of trained healthcare staff and health services. There is high cost of treatment, long queues and long waiting lines for basic treatment at government hospitals. Doctors need to not only diagnose and treat thousands of patients, but also write hundreds of case sheets, discharge summaries, reports, and sift through thousands of x-rays and lab reports daily. Highly overburdened and have to frequently face the wrath of distraughted patients or their relatives. So AI seems to be the magic wand that can help us in moving away from the traditional one-size-fits-all healthcare system to an era of precision medicine and safer, targeted, and personalized treatments. A revolutionary approach for disease prevention and treatment that takes into account individual differences in lifestyle, environment, and biology. So recent developments, AI is now developing into human genomics and finding the perfect treatment suited for every individual based on his or her genetic makeup. It analyzes molecules and predicts how they will act in the human body, including their potential efficacy, toxicity, side effects at an earlier stage than in the traditional Intel-Xenon drug discovery process. So these are the various list of companies already using IA in healthcare. But what are the challenges and what is the way forward? So again, let's decide. Is it really as dangerous? Is it an asset we can use to our advantage? Will AI make human doctors redundant? Will humanity always win in the end? Thank you so much. Any questions from the audience? Thank you, everyone.
Thank you, ma'am, for your fantastic performance. Now I'm pleased to hand the mic to Dr. Rohit Raina, Assistant Professor, Department of Medicine in AIIMS, Bathinda, to present his topic, Impact of Undernutrition in Diabetes.
Good afternoon, everyone. So I want to thank the organizing committee for giving me opportunity to speak on this platform. We all know as diabetes is a disease of overnutrition. Let's discuss about the undernutrition in diabetes. So regarding this topic, we are here with this impact of undernutrition on the clinical outcome of diabetic patients. And malnutrition refers to getting too much or too little of certain nutrients, and it can be classified as undernutrition or overnutrition. So what's undernutrition? It causes weight loss and fatigue, and there are some mineral and vitamin deficiencies which are attributed to undernutrition. And whereas overnutrition can lead to overweight, obesity, and inadequate micronutrient deficiencies. So American Society of Enteral and Parenteral Nutrition, it defined this malnutrition as an acute or subacute or chronic state of nutrition in which there are varying degrees of undernutrition or overnutrition with or without inflammatory activity, and that have led to a change in the body composition and diminished function. And it can be both undernutrition and undernutrition. So as obesity has been recognized as a risk factor for diabetes, malnutrition has its potential effects in the development of insulin-dependent diabetes mellitus. And this WHO, it defined malnutrition as a clinical entity as malnutrition-related diabetes mellitus in 1985. So what is the classification of MRDM? It's of two subgroups. First is the fibrocalcific or fibrocalcous pancreatic diabetes, and second is PDDM, protein deficient pancreatic diabetes. So let's go with the case in our OPD. A 35-year-old male presented to OPD with history of polyuria, polydipsia, and weight loss, and he has a history of treatment for refractory chronic pancreatitis, for which the surgery was done. His blood sugars were 520 to 520, and HbA1c was 12.6. So we did an abdominal X-ray, and this was the X-ray. There was extensive pancreatic calcification in the X-ray, and we go with the diagnosis of fibrocalcific pancreatic diabetes. So the approach to fibrocalcific pancreatic diabetes is that whenever you see a patient, young, lean patient with diabetes, either it can be of acute onset or insidious onset. If there is no pancreatic calcification and the ketosis is positive, these patients usually respond to insulin, not to drugs. So we classify these patients as type 1 diabetes. But if the diabetes of insidious onset, there is pancreatic calcification, there is no ketosis, so these patients respond to insulin and sometimes to OHAs also. You classify these patients as fibrocalcific pancreatic diabetes. Let's go with the second case. There was a 40-year-old female, known case of hypertension, and was diagnosed as type 2 diabetes mellitus, was on oral medications, and presented to OPD with history of palpitations, weight loss, and loose stools. So she was bedridden for last 2 months, and with this complaint, she presented with hyperglycemias, and we started on insulin therapy, and she developed hypoglycemias. So she had she was severely malnourished with BMI of 13.5. So the X-ray abdomen was done, but it was normal. So it was done to rule out FCPD, but it was normal. So what was the likely diagnosis? It was possibly PDDM, protein deficient pancreatic diabetes, or also known as protein deficient diabetes mellitus. So some bit about this. So it is similar to FCPD, but there is absence of radiological or clinical dysfunction, pancreatic dysfunction. And they have a clinical feature of low BMI, and there are symptoms of malnutrition and growth retardation. You can see the patients with ketosis resistance because of subnormal beta cell function that leads to insulin interruption. And there is shrunken pancreas without calculi and without some polymorphic infiltration. In addition to, there are extensive fibrosis of the pancreas. And there is a deficiency of micronutrients, which initiates the functional impairment of the pancreatic beta cells. So this article published in International Journal of Research and Review showed that malnutrition is related to deficient micronutrient and macronutrient, and maternal malnutrition during pregnancy is the rare risk factor which causes decrease in the fetal intrauterine development and leads to insulin deficiency, glucose intolerance, and insulin resistance in the Indian population. So that's why there is an evidence-based individualized nutrition therapy in these patients. So how does this prenatal malnutrition induce epigenetic dysregulation as a risk factor for type 2 diabetes mellitus? So this suboptimal maternal malnutrition is defined as a big risk factor along with this maternal nutrient restriction and gestational diabetes. So there is deranged cellular energy metabolism, glucose handling, lipid metabolism, and mitochondrial biogenesis, which leads to insulin resistance, hyperglycemia, hyperinsulinemia, cardiovascular deaths, and obesity. So in this diagram, you see that nutrition-poor environment in pregnancy is defined as a biggest risk factor for the offsprings to have diabetes and to have malnutrition in the diabetes. So let's go with the IUGR-induced epigenetic changes, which was shown that maternal drug use, maternal alcohol use, maternal smoking, and prenatal stress, hypoxia, malnutrition, these are all the risk factors for IUGR-induced epigenetic changes which have led to type 2 diabetes in the offspring. This article published in International Journal of Nutrition, Metabolism, Health Sciences reveals that we should go for the must screening tools, like simple screening tools, to identify the nutrition status of patients in diabetes in OPD settings. So let's classify malnutrition. So it is of 3 types. First is the disease-related malnutrition with inflammation. Second is disease-related malnutrition without inflammation. And second is malnutrition without disease. So this disease-related malnutrition is divided into 2. Acute disease-related or chronic disease-related malnutrition, and this can be of cancer cachexia malnutrition. And second, malnutrition or undernutrition without diabetes, it is of socioeconomic state due to socioeconomic status and hunger-related malnutrition. And you can see this undernutrition composes of 25% of the patients, diabetic patients, who have tendency to go with diabetes in the future events. So one more article published in this Hindavi, it stated that the patients who had CKD with diabetes had highest risk factor of malnutrition and more chances of having death in the patients without diabetes. So whether type 1 diabetes is a resource poor setting or malnutrition related or malnutrition modified or just diabetes. So it's of 2 types, resource poor or Western. So you can see that resource poor are more associated with markers of undernutrition as compared to Western, which are associated with increased child growth. So associations of different. So in critically ill patients who have malnutrition, you can see that severely malnourished patients had higher longer duration of stay as compared to well-nourished patients, and as highest degree of malnutrition, and they were associated with higher mortalities. So you can see this graph. The well-nourished people were 16%, whereas moderately malnourished were 50% and severe were 34%. Well-nourished people had lower mortality, as well as severely malnourished had higher mortality, as 9 times more than the other people. So you can see that the malnutrition is associated with worse outcomes among hospitalized individuals with diabetes, and these patients have a longer duration of stay and 9 times higher risk of dying. So let's define what is sarcopenia and malnutrition. Both are different terms, and sarcopenia just overlaps with the malnutrition. And you must know that pre-sarcopenia is characterized by reduced muscle mass, but there is no reduction in muscle strength or physical performance. While as the sarcopenia is characterized by presence of low muscle mass along with low muscle function also. So there are few effects of sarcopenia on the body. There's increase in patient length of stay, there's decline of the daily activities, reduced day-to-day activities, increased risk of illness, poor wound healing, and increased mortality. This article published in the Progress in Nutrition 2018 showed that 1 in every 4 patients admitted with type 2 diabetes had malnutrition or had malnutrition risk as in patients if they are overweight. So malnutrition was more prevalent in the patients which were admitted with diabetes. So you can see that 1 in 3 patients, whenever they enter a hospital, they are malnourished. So this was another article published in BMJ. It showed that the ischemic heart disease, AMI, acute myocardial infarction, stroke, COPDs, all these events were more prevalent in patients with diabetes, and the hazard ratio was 1.62, 1.47, 1.59, and 1.66 respectively as compared to the hazard ratio in patients without diabetes. This Kaplan-Meier curve suggests that malnutrition in patients without diabetes, the half-life was 2.38, whereas the patients without diabetes, it was 5.08 years. So let's go about why there is malnutrition in diabetes, and you can see an article published by Jasbir S. Bajaj, and there was this non-insulin type 2 diabetes mellitus is associated with overnutrition, but yes, it's also associated with undernutrition, and that's why, because of high probability of tuberculosis among the diabetes, there is a need for doing chest X-ray in all patients with diabetes to rule out tuberculosis. And tuberculosis is a high risk factor for patients with insulin resistance. So there is one more term called malnutrition or obesity. So all these micronutrient deficiencies, they are the culprits in causing diabetes. And you can see that there are some specific multivitamins or some minerals which impair their roles in glucose metabolism and insulin signaling pathways, and they are the culprits in causing diabetes. So you can see thiamine, B12, vitamin D, chromium, and these are all the micronutrients which can promote diabetes in the later onsets. So you can see vitamin D leads to the prevalence of deficiency is 85 to 90% in both in obesity and type 2 diabetes mellitus. So these are various micronutrients. So whenever there are altered levels of zinc, chromium, selenium, calcium, boron, iodine, magnesium, iron, they lead to increased oxidative stress, lead to increased insulin resistance, and lead to diabetes. So what are the risk factors for the same? They are the geriatric-induced risk factors at advancing age. Second are the modified risk factors like smoking, nutrition overload, nutrition deficiencies. Third is the maternal malnutrition. And fourth are the pediatric-induced factors, as I discussed in the previous slides, like poor growth development and low birth weight. This is a vicious cycle of micronutrient deficiencies and supplementation. You can see micronutrient deficiencies, it can lead to oxidative stress, inflammation, immune dysfunction, defective beta cell, defective enzyme activities, beta cell apoptosis, impaired compensated hyperinsulinemias, insulin resistance, and again syndrome X, hypertension, type 2 diabetes, dyslipidemia, hyperuricemia. So this is a vicious cycle of micronutrient deficiency leading to oxidative stress and then to diabetes. So how do this micronutrient lead to diabetes? So all the deficiencies lead to activation of insulin receptor phosphatases and defective tyrosine kinase activities, and they are the biggest culprit in causing the diabetes. So vitamin D in diabetes, it is also prone to cause it can be autoimmune dysfunction of pancreatic beta cells, or there is impaired sensitivity on glycometabolism. And this autoimmune destruction of beta cells can lead to type 1 diabetes, and impaired insulin sensitivity can lead to type 2 diabetes. So whenever we see that whenever we supplement vitamin D with calcium, it had a good response, and there was change in fasting plasma glucose by 13 millimole per milligram per ml, and you can see this vitamin D deficient individuals with vitamin D less than 13.9 had highest hazard ratio 2.303 in terms of all-cause mortality and CV mortality. So what are the causes and effects of malnutrition in elderly? You can see poor immune function, dysregulation, appetite and thirst, sensory changes, and reduction in gastric excretion. So all of these are the reasons for the malnutrition in elderly: depression, polypharmacy, injury, falls, bone fractures, disability, urinary incontinence, cardiovascular disorders, cognitive decline. There are few malnutrition screening tools like malnutrition screening tool, mini nutrition assessment, SNAG questionnaire, MUST questionnaire. So all of these are used in our OPDs and in our wards to look for the malnutrition in the patients with diabetes or without diabetes. So there are a few goals of malnutrition therapy. First of all, the biggest goal is the healthy full eating patterns with variety of nutrient-dense foods and portion sizes. Second is the individual-based nutrition therapy, the pleasure of eating, to maintain pleasure of eating and to go for the practical tools. And remember one thing, one size doesn't fit for all. You have to go with the different sizes of all patients. And so for type, we have to achieve this plate method of changing the plate from non-starchy vegetables, 1/2 of the plate, and other plate will serve, 1/2 will serve protein-rich foods and grains and starchy foods. So as a take-home message, the nutrition therapy is recommended for all individuals with diabetes as a necessary component of treatment plan. In type 2 diabetes, 3 out of 4 patients are mostly obese and overweight. While in type 1 diabetes, the patients are underweight. The older individuals are at high risk of undernutrition due to anorexia, weight loss, altered taste, smell, swallowing difficulties, and function impairment. And they are high risk of nutrient deficiencies. And it has been seen that vitamin D patients, the diet in vitamin D and low in vitamin D and vitamin B have been a biggest risk for patients with type 2 diabetes. We have to go for specific assessment of nutrition in elderly, as going with the patient medical history, a diet plan, areas of dietary intervention, and monitoring the progress. So always I will go with this wording: eat right, move more. So food, glorious food, eat too much and suffer. Carbs to be counted, take a bit fiber. Balance your diet with the greens from the racks, avoid oil, ensure 3 meals and 3 snacks. Thank you. Any questions? Thank you, Irvin.
Thank you, sir, for this amazing presentation. But now I'm excited to welcome Mr. Sandeep Aroda, founder of Udesha Wealth and certified wealth manager, to share his presentation on topic financial planning for doctors.
Good afternoon, everyone. It's a tough time after lunch to make a presentation. So what I'll do, I'll try to make it a little interesting, and especially when all of you are from the finance background, from the medical background, and a lecture in the finance will be something little different for you. But we call ourselves as financial doctors. You take care of our health and we take care of your finances. So I'll start with a quick question. Maybe anyone out of the audience, if you can answer, I'll request for your attention here. See, if we save 1 rupee on a day, and next day we save 2 rupees, third day we save 4 rupees, every day we are doubling our saving. So by 30th day, how much will it become? Any guesses, any answers? I'll repeat it again. On first day, we saved 1 rupee. On second day, we saved double of that, that is 2 rupees. Third day, we saved again double of that, 4 rupees. So by 30th day, how much will it become if we keep on doubling our saving every day? So you will be amazed to know that it will become more than 53 crores. That's the power of compounding. The bad part is, or the sad part is, it will be difficult to double our money every day. But the good part is, during our working life, or I'll say till the time we retire, up to the age of 55 or 60 years, even if we are able to achieve 8 to 10 doubling cycles, that is more than enough to take care of all our life goals. So with that, I'll start my presentation. So basically, our life, or the working life, revolves around earning, spending, and saving. So these are the three things. Once we start earning, we feel on the top of the world. But the issue is, the moment we start earning, our expenses also start increasing. And end of the day, there is always a fight between the expenses and the savings. So these are the challenges which we are facing, or especially the younger generation which is facing. With the money coming in, you have your credit card bills, you have your multiple EMIs running, the overspending is there, and end of the day, you are not left with any savings or any emergency funds. There is a 50-30-20 budgeting rule. What does it say? If you are earning 100 rupees, spend 50% on the essentials, 30% on your wants, and 20% on your 20% you should save. What is the difference between essentials and wants? I'll just explain it in the coming slides. So basically, the essentials or the needs are whatever is must for us, like your home is must for you, your daily basic food is must for you, the utilities, the electricity bill, the telephone bills, those are the must for you, the medicines, the education for your kids, that is must. And want is anything over and above, which is basically, we can also call it as whatever are the expenses for the entertainment. So there, yes, that is required for us, but it is not must. It's not that without that we cannot live. There is no end to the wants. In fact, few of you, or whomsoever out of you have heard of Warren Buffett, he had said, if you buy things you don't need, soon you will have to sell things you need. So the new rule is, the old rule I have shared with you, 50-20, 30-20, 50% should be your expenses, 30% should be on your, 50% is on essentials, 30% is on wants, and 20% you should save. So, but the new rule is, essentials is must. If you are earning 100 rupees, out of that, essentials you cannot avoid. Your day-to-day, the compulsory expenses, that has to be there. But after that, you first decide, okay, how much can you save? And the golden rule is your target, especially for the youngsters, a lot of the students are here. So make it a point, moment you start earning, 30% of your salary or 30% of your earnings, you will start saving. And believe me, your wants, once you decide on the saving amount, your wants, you will be able to adjust it accordingly. And these are the few rules which will tell you you are financially stable. Basically, you are paying your bills on time. You are using credit card only for convenience. Nowadays, what is happening is the products are available on EMI. Many of us are buying the products on EMI. And finally, at some stage, you have 4 or 5 credit card EMIs running, which is more than 30, 40, 50,000 rupees per month. So which is a big drain on your earnings. So basically, once you decide on the saving part, you will have to start investing it systematically, and you should have some emergency fund also. So a big part of financial stability is you should be very clear. Never that question should come into your mind, what if? What does it mean, what if? What if something happens to me? What if I don't have a job? At least at some part, or at some stage of your life, once you start earning, you should come out of this what if. You should be financially comfortable so that even if you are there or not there, your family is comfortable or their future is secured. So next part is managing and reducing debt. Basically, there are two types of loans, good loans and bad loans. Again, whatever is essential for life, that is good loan. Home loan, education loan, business loan, all these are good loans. Bad loans are whatever is related to your wants, your personal loan, your car loan, your credit card loan. I just touched upon that, your consumer loans, all those are bad loans. Basically, the good loans, whether it's education loan, home loan, you get the tax rebate also. Income tax rebate is available. So your final rate of interest, what you are paying is almost, it is less than 7%. Like for education loan, it is coming to less than 7%, and for home loan, it is coming to less than 5%. So all that is 5, whereas for all other loans, you see it is almost into the double digits, which is not at all desirable. So planning for future. We talked about saving, now we'll talk about, okay, why we save. Basically, you save for your future goals. Like the key future goals are, once you go into the family way, the education, higher education, first it is your dream home, then it is higher education of your kids. The vacation can be there, the marriage of your children can be there, and finally it's your retirement, which is your biggest goal. Why it is your biggest goal? See, life is basically, it's three parts. Up to 25 to 30, it is the youth stage, and then it is the family stage from 25, 30 till 55, 60 years of age. And from 55, 60 till 80, 85, the last 25 to 30 years of your life, you are without any income in most of the cases. So whatever you have earned, and out of that, whatever you have saved and invested after taking care of your major life goals till that time, that has to take care of your last 20, 25 years of retirement life. So it's upon you. If you are saving well, if you are investing well, that can be the retirement. We generally call it as the second inning, or it can become the best part of your life if you have saved well and invested well. Otherwise, there can be challenges during that stage of the life. So what do we expect from our investments? Basically, it's safety and security, tax efficiency, regular returns, and easy liquidity. I'll cover it up in the next few slides. See, we are earning 100 rupees, or say we are saving 100 rupees. If we are this 100 rupees, if we are just keeping it in the bank locker, over a period of time, its value will reduce. What does it mean? Like in today, for 100 rupees, if you are able to buy 2 kgs of atta or 2 kgs of wheat flour, after 10 years, you may not be even able to buy half a kg of wheat flour. So keeping it in the bank locker, it's not going to serve the purpose. You have to invest it into the right products. I said it initially, during your lifetime or during your working life up to the age of 55, 60, if you are able to achieve 8 to 10 doubling cycles of your money, that is more than enough to take care of all your life goals. I'll again cover it up in the next slides. So what are the various investment options? Most of us are aware. The stocks, the most prevalent one in India is bank deposits, then property. A lot of people have passion for investing in property. Insurance is there, insurance cum investment plans. We call it as endowment plans. That is there. Bonds are there, government bonds are there, stock market shares are there, and the gold is there. And as far as share market or the stocks are concerned, there are two ways to invest in that, either directly into the equity market or through mutual funds. So I'll just cover all 7 or 6 or 7 in the last slide, what we talked about. It will not be possible to cover due to paucity of time. But quickly, the most famous ones or the most prevalent ones I'll try to cover. See, FD, as I said, most of the Indians are putting their money into FD. But the challenge with FD is, I have just given the 10-year chart here, FD versus inflation. So if your 100 rupees FD, in 10 years it is becoming 201 rupees. But the cost, due to cost of inflation, whatever you are buying in 100 rupees today, you will need 181 rupees or 182 rupees after 10 years. So there is hardly anything left with you. But the story doesn't end here. Point is, whatever we are earning through FD, like the present rate we have assumed is 7.25%, out of that, depending upon your income tax slab, a big part is going towards the income taxes. So for those into the highest tax slab of 30%, after paying the tax, what is happening after 10 years? Due to cost of inflation, against 100 rupees, you need 182 rupees. But after paying taxes, you are left with only 164 rupees. So whatever you are earning in the FDs, it is not even covering your basic cost of inflation after paying the income tax. So FD, we generally don't recommend at all. Some emergency fund is required, which generally it is equal to your 6 months of monthly expenses. Keeping that into the FD, keeping that into the bank account or into the debt mutual funds, that is fine. But anything over and above bank fixed deposits, it's not the optimal investment option for the growth of your money. So this is a quick chart giving the returns during the almost last, from 1979 to 2023, of the various products. So the equity or the stock market has given more than 15% returns. Gold is almost 10%. Fixed deposit is at 7.7%. And inflation, the cost of inflation is as good as what you are earning out of fixed deposits. So basically, in the next few slides, I am only going to talk about the equity, or basically the investment into the equity through the mutual fund route. See, many people whom we meet or who consult us, their worry about the equity or the stock market is it's very risky or it's very volatile. The point is, for short term, we don't recommend equity. Short term is anything less than, say, 3 years or 4 years. Anything above 5 years, this is the best option available for you through the mutual fund route. Why this is the best option? You have to understand the concept. What exactly is happening through mutual fund? See, through mutual fund, through these professional mutual fund houses, each mutual fund scheme has a fund manager, he has a scheme of analysts. You are investing into the best of the Indian companies. And these companies, over a period of time, in the long term, they are going to grow. Short term volatility can be there due to the political news, due to the market, due to the various factors. Like during the COVID time, the market went down. Then during Russia-Ukraine war, the market was again down for some time. But then over a period of time, it covers up. So if you see, 1 year you will see 14 out of 44 years, there is a negative return. 5 years, if we see, it is only 2 out of 39. Anything above 10 years, every time it is positive. So more than 5 years, there is no better option than the mutual funds. I have touched upon this, why mutual funds, professional management, there is a lower expense, liquidity in nowadays, in today's time. Today if you need some money, today if you give the request for redemption, tomorrow or day after tomorrow, the money will directly be credited into your bank account. So it is as fast, as convenient, and as hassle-free. These are the returns given by various categories of mutual funds, as you can see. Even if we look at the lowest return, which is in the third column, it is 10.65% and 10.58% for 2 of the categories. But even that is much better than what you are getting into the fixed deposits. And as I said, even the tax rate, like whenever you are selling it after keeping it for more than a year, the income tax rate is only 12.5% as compared to 30% in the highest tax slab in case of the bank fixed deposits. So stay disciplined, invest regularly. What I'll do is I'll now just try to touch upon few of the illustrations, which will give you some idea about the power of compounding. Due to paucity of time, I'm just hurrying up. So basically, for your retirement, if your present expenses are, if you're 30 years old and if your present expenses are 50,000 per month, after 30 years, you will need a corpus of 8.37 crores for your balance period of life to maintain the same standard of living. And for that, after meeting your goals, if you don't start now, after meeting your goals, you may or you may not have 8.37 CR at the time of your retirement. So the best way is when you are 30 years of age, straight away at that time itself, you start an SIP of 27,000. And as I started my presentation, due to the power of compounding, by the time you reach your retirement age, that SIP of 27,000, SIP is systematic investment plan, you are investing on monthly basis. It automatically gets debited from your bank account and it gets invested through the mutual fund into the equity market. So that will ensure that you have the money of 8.37 CR at the time of your retirement for your balanced 25 to 30 years of retired life. So many of the youngsters are there. There is another way. Again, this will show you the power of compounding. By 30 years, we start earning at the age of 25. Or whatever age, some will start earning at 25 in medical profession, maybe it can be at 27, 28. Just give attention to this slide. In first 5 years of your working life, you can plan for your retirement. How that is possible? Just start an SIP of 25,000 per month for first 5 years. That is basically you are investing 15 lakhs of money during your first 5 years of working life, and then don't touch that money. You can by that, after first 5 years, you may get married, you will go into the family life, you may not be able to continue with the SIP, but don't touch that money which you have invested during the first 5 years through the SIP route. And at the time of your retirement, at 12% return, I have showed in the previous slides, most of the mutual fund schemes have given more than 12% returns. But at 12% return, that amount will become 6 crores, and at 13% return, that amount will become 8 crores. So it will take care of your retirement life peacefully. Just by investing 25,000 per month for the first 5 years of your working life, you have assured your retirement life. There cannot be any better solution or better investment option than this. Another illustration I am giving is the best gift for your newborn child. See, many times as a parent, the moment the child is born, we'll look at the various options. So here I have given the illustration. You just start an SIP of 5,000. Moment your child is born, start an SIP of 5,000 for him or her. He or she will take care till the time you will take care till the time they start earning, or say around 25 years of age. And after that, they will take care of that SIP. And over a period of time, for the period of 60 years, if this SIP is continued, for the children, it will amount to, or for that child, it will amount to 75 crores of amount. So just with an SIP of 5,000, it can take care of all his life goals. First 25 years, you are paying that 5,000. After 25 years, or once he starts earning, he is paying that 5,000. And this total amount with this 5,000, a small SIP of 5,000 per month, it is working out to 75 crores. Not only retirement, it will take care of all his life goals which are coming during his various stages of life. Whether it is buying a house or whether it is higher education of his children, everything will be taken care. The last illustration is whether your clinic, whether you want to buy it through EMI. EMI is basically taking a loan and going for it by making your clinic, or have patients for 5 years, save some money for 5 years, start an SIP of, I have taken the target amount as 30 lakhs, assuming the 30 lakhs on average should be enough for starting your own clinic. So for 5 years, just if you start an SIP of 36,000 rupees, with a step up is every year you are increasing the SIP amount by 10%. So by doing that, you will be able to get at 13% return, you will be able to get 30 lakhs amount in 5 years. So choice is purely yours, whether you want to take the loan. If you are taking the loan during a period of 10 years, if your loan is 30 lakhs, you will be paying almost the same amount as interest. So it's purely your choice, whether you want to go through the EMI route or whether you want to go through the SIP route. That's it from my side. Thanks a lot. Any questions? In fact, I'm here for next 4 days. My stall is there outside. Any one of you interested in planning for the target amount for your investment or goals, you are most welcome to contact me. Any questions for the time being? Thank you. Thanks a lot.
Thank you for sharing your knowledge, sir. Now let's turn our attention to Dr. Rakesh Kakkad, Professor and Head of Department of Community and Family Medicine of AIIMS Bathinda, to share his presentation, One Health Approach to Address Zoonotic Diseases.
Very good afternoon to all. First, I would like to thank the organizer Dr. Vitul for this opportunity. But the purpose of my presentation would be more better if, because it is about the integration and developing a good health system. And yesterday I was there in ministry to for a workshop where we are planning to develop a good health system. So various clinicians and other departments were there to develop a climate change. What are the health impacts of those things? So this One Health approach is all about that, and that is we need collaboration, coordination, and communication between three important sectors, that is human health, animal health, and environmental health. So we cannot see this nowadays, these things alone. We need coordination. And every time we see in Kerala, every time they come up with a new cases like nymph virus or swine flu or something new, like monkeypox also they have detected recently. So their system is very well developed, and so this need coordination of all clinicians, whether in government sector or private sector, from the health side, and other sectors are also important for developing such things. And I am happy to inform that we are already running sentinel surveillance site from last 2 years, and now we are regional coordinating center for this region for National One Health Program for prevention and control of zoonosis. So under this program, we have strengthened our lab. So microbiology lab, now we have a capacity of diagnosing brucellosis, leptospirosis, and many more priority diseases. And we are, every year we are increasing our facilities. But so as to identify these infections at the ground root level, so we'll get referral of these cases. Otherwise, these cases will be missed. Clinicians will simply diagnose a case of fever because lab facilities, if these are not available, then these cases will be missed. So we are planning to sensitize all the clinicians about these priority diseases so these are not missed. And proper history taking is also required so that if person is coming from some endemic area or from any endemic country, so one can suspect of these zoonotic diseases. So being a regional coordinating center, we are trying to invite all the stakeholders and agriculturists, veterinary surgeons, animal husbandry, fishery, so that if any unusual case is reported there, so if they will inform us or we will inform them, so with a proper coordination, we can easily diagnose such cases and early action can be taken. So what is the importance of One Health? Like most emerging infectious diseases, that is around 60% are zoonotic in origin. And out of these infectious diseases, if we see in last 3 decades, more than 30 new viruses have emerged. And these around 70 to 75% of these viruses are originate from the wildlife or from the animal origin. And the other important thing is an estimated 1.7 million undiscovered viruses still exist in mammals, avian host, and almost half of which have the ability to infect. So there is a huge potential of epidemic lying there. So we have to recognize, we'll discuss more about what are the ways to discover this, these infections. So, and if you will see in last 20-30 years, all the infections, major epidemics are due to the viral infections. And because of no immunity, every time we land up into a huge epidemics. Like in last 10-20 years, severe acute respiratory syndrome, SARS in 2003, Ebola virus infection in 2005, and again in 2017, H1N1 flu, Zika virus, MERS, Nipah virus, COVID-19, monkeypox. So all these are viral in origin. And all these, there is no preparation of our health system because these infections are new to the system. So in this slide also you can see from last 20-30 years, many such episodes happened, and our system is always overburdened with such cases. And there's a huge panic also in the community. So what are the factors responsible for disease emergence? Like wildlife forest encroachment. Usually now people are encroaching forest for getting more space because of increased travel globally. So infections spread rapidly. Because of intensive livestock farming practices and growing demand for protein-rich diet, we are dependent on such sources. Because of poor sanitation, because of environmental changes leading to increase in vector population. Again, in the flu viruses, there is a chances of mutations. So that again increases the chances of newer infections. Then air pollution. Air pollution is a big factor for cardiovascular diseases now. Increased population, urban expansion, and land use change, deforestation. So all these factors, and these are anthropogenic factors, and all the infections we have seen in the last slide is due to our anthropogenic efforts that are not sudden, but it is due to our lifestyle. So due to human activity now at rural, urban, and mobile communities at local or national level, and if there is an imbalance between all these three, that is environment, human, and animal, then it can result in more such infection. Due to climate changes, with a 1 degree or 1.5 degree rise in temperature, there are increased chances of vector-borne diseases. So it increases the chances. So there is a need between coordination, communication, capacity building of our health worker is required so as to have a good One Health, that is healthy ecosystem, healthy humans, and healthy animals. So now there's a big umbrella, that is a proper coordination is required at every level, that is environmental health, ecology, veterinary medicine, public health, human medicine, molecular microbiology. So we cannot see now patient alone, but if any clinician is noticing any abnormal phenomena, unusual thing, then he should report to the health authorities like this is done in the Kerala. So every time they detect it quickly and take proper action, and that is how they subside the infection and control the infection. So all these infections due to zoonotic diseases and our health system like comparative medicine or translational medicine. So cancer, cardiovascular diseases in humans and animals, and environmental exposure, metabolic disorder, everything can be controlled by One Health approach. So the aim of this program is to respond to the zoonotic disease outbreak using a One Health approach. So multidisciplinary involvement is required with a relevant expertise for protecting people, animals, and economies. So, in last few slides, I have focused more towards the infectious disease, but these infectious diseases alone is not under One Health, but since environment is involved, so it is beyond that, that is infectious, non-infectious, and injuries also are covered. So communicable, non-communicable, and injuries, everything is covered. Like during winter months, due to lot of fog, a lot of accidents are being reported. So fog is a combination of water and dust. So this can cause, so we have to keep a control on our environment to reduce the injuries. So anthropogenic stressors to the environment enhance and exacerbate disease that animals mediate to humans. So in this sylvatic cycle, usually the animal viruses with a high host plasticity remain concentrated there, but because of interaction between the wild animals with the domestic animals or human activity at the wildlife, there is a spillover, and then stage 1 crosses to stage 2 and animal to human infection sets in, and then human to human transmission starts. So with increased mobility, a spillover event lead to multi-country or global threat. So what is needed? What are the preventive strategies so that we can reduce the infection from the wildlife to the domestic animal or to the humans? So we have to share the epidemiological data at various levels. We have to do routine testing of sentinel species, identifying and vaccinating high-risk group, and limit wildlife domestic contact with fences or planning around migratory routes. So no one is spared from this infection. So involvement of everyone is required for developing a good health system. So like in, again, this slide you can see, we need to sensitize, we have to develop a capacity of various sectors, and infection care models are now available, so we can predict infections in advance. Like if you want to contain the spread of dengue virus, now models are available through which we can predict 2 months in advance about such infections. So prediction is possible, so we can do good detection and control these well in advance. This is how we can improve our health system. So this is the strategy of developing the health system, but I think I'll skip it. This tells us how we can develop a consensus among various sectors. Political will is required, and how we can develop a good health system. So these are the preparedness strategy for zoonotic disease. These are 7 key strategies. That is the strategic planning, financing, leadership, and governance. And we have to develop a collaborative surveillance. So collaborative surveillance not only at the health level, but also at the veterinary surgeons level, and reporting, cross-reporting is required. So that we can develop early warning systems. Through early warning, we can take adequate measures. So there is a need of workforce development. We have to develop our laboratories to tackle with such infections, newer infections. Hospital preparedness is required, and managing surge capacity, and always there is a scope of operational research, of developing a health system research models. In many of the states now, wastewater surveillance is in process. So wastewater surveillance, that is, they try to detect early through the sewage water, through the hospital waste. They detect the viruses and bacteria, excessive use of drugs. So this sets in the early warning for infectious disease outbreak. So this system can also detect the multi-drug resistant pathogens. Under this environmental control, we can have a better surveillance of water and soil pollution so that we can detect arsenic poison or lead poisoning. So these factors also one has to keep in mind if certain symptoms are being reported, like hyperkeratosis or increased cancer risk, lung, bladder or kidney due to arsenic poisoning, or symptoms which are suggestive of lead poisoning. Again, air pollution, it enhances the chances of many respiratory infection and cardiovascular infection. So every time we notice air pollutants, so one can suspect, like in Delhi, there are more chances of morbidity and mortality due to these factors. Okay. So if we'll stop such infections well in time, then we can reduce the cost of control outbreak. So what are the priority zoonotic diseases which are there in this program and which we are trying to develop at our laboratories? So zoonotic influenza, anthrax, Japanese encephalitis, leptospirosis, brucellosis, dengue, rabies, scrub typhus, plague, and CCHF. So these are the 10 priority diseases which are covered under One Health. And we are doing a hospital-based surveillance as well as surveillance at the community level. So there is a need of integration, and you can see the green zone, that is cross notification between the veterinary and health sector, that is human health. So again, you can see the green bars. On the one side there is a government system, and on another side there is a private sector. So we need to collaborate at various levels. At district level, there is a proper coordination is required, so information can percolate from district to state and state to central surveillance unit. So again, the coordination is required at various levels. So prevention, preparedness, and response is required. So PRP is required for prevention, so I will not take much time because time is already over. So there are few cases of, that is after flood, we can anticipate leptospira infection. After earthquake, which we have seen in Surat in 1994, there is a sudden rise of plague infection, bubonic plague. Then West Nile fever, salmonella infection after the party due to salmonella in the eggs. So after eating egg curry, one can notice gastroenteritis. So such things are there, and one has to be vigilant to cover these things. So again, with the cross notification, our system has identified avian influenza or Lyme's disease. So these are some of the vulnerabilities for respiratory pathogen, and respiratory pathogens are most rapidly spread, and all in the last decades we have noticed viral infection, and most of these are respiratory infections. So these are some of the trigger points which increases the chances of suspicion or epidemic investigation. This is the combined chart which we can develop and we can discuss later how we can detect these such infections in an integrated manner. So thank you.
Thank you, sir. I sincerely appreciate your efforts and hard work. Now I would like to call Dr. Anir Kumar Goyal, Professor and Head of Radiation Oncology at AIIMS Bathinda, to share his presentation on recent advances in management of advanced prostate cancer.
Good afternoon, everyone. I am really honored, and this is a matter of pride for me for being invited as a speaker in this prestigious conference, wonderfully organized by Dr. Vitul Gupta and his dynamic team. My topic of discussion today is recent advances in management of advanced prostate cancer. I will start with the epidemiology of the prostate cancer in brief. Then we will discuss risk stratification based on serum PSA level, Gleason score, and clinical stage. Then diagnostic workup of the prostate cancer will be discussed. And after that, the management protocols, including the principles of surgery, radiotherapy, androgen deprivation therapy, chemotherapy, and immunotherapy. So prostate cancer is second most common cancer in males worldwide after lung cancer. And in India, the age-adjusted rate is 5 to 9 per 1 lakh population, which is much less than the age-adjusted rate in Australia, New Zealand, North America, or Europe, where it varies from 60 to 80 per 1 lakh population. Now, the advanced prostate cancer will include the clinical stage T2, T3, and T4, and there are 5 grades based on the Gleason score on pathological report. Grade 1 is Gleason score 6, 3 plus 3, 6, that is only the well-formed glands are there. Then grade 2 is 3 plus 4, 7, that is predominantly they are well-formed gland, but a small component of poorly formed glands. Then grade 3 is again 7, but is 4 plus 3, 7. That is predominantly they are poorly formed gland and a small component of well-formed gland. Then grade 4 is Gleason score 8 and 5 is 9, 10. Now, ultimately, the high-risk prostate cancer will include the unfavorable intermediate risk, high risk, and very high risk. So what is unfavorable intermediate risk? So this will include any of these 3. That is, if the Gleason score is 4 plus 3, 7, if more than 50% biopsy scores are positive, or if 2 or 3 of the all intermediate risk factors are there. That is T2B, T2C. T2 is if the cancer is confined to the prostate gland. T2B is more than half of one side is involved. T2C is both the sides are involved. And then Gleason score 7 and PSA 10 to 20 nanogram per ml. High risk will include any of these. T3A, that means unilateral or bilateral extraprostatic extension, Gleason score 8, 9, 10, or PSA more than 20 nanogram per ml. And while very high risk prostate cancer will include any of these. T3B means involvement of seminal vesicles, and T4 means involvement of other organs other than seminal vesicle like rectum, bladder, or external sphincter. And Gleason score 9, 10, and more than 4 cores with Gleason score 8, 9, 10. Now, what is the diagnostic workup in advanced prostate cancer? So, digital rectal examination, ultrasonography, especially TRUS, these have reasonable sensitivity and specificity, and these are the gold standard for initial evaluation of the advanced prostate cancer. Then CT scan, abdomen and pelvis, MRI, especially multiparametric MRI scan, bone scan. It is not so popular these days. So, the imaging modality of choice is PSMA, that is prostate-specific membrane antigen-based PET CT scan. Now, transrectal ultrasonography is used to take multi-core biopsy from the prostate gland, and typically minimum 12 cores are taken. But if you are fusing the TRUS with multiparametric MRI, then even more than 12 cores can also be taken. CT scan, abdomen and pelvis is indicated if the predicted lymph node metastasis risk is more than 10%. And this is deduced by Roche formula. And there is recently updation of Roche formula, that is Yale formula, which involves clinical stage apart from PS and Gleason score. And you just fill the value, you get the result. And if the lymph node metastasis risk is more than 10%, then CT scan abdominal pelvis is indicated. But CT scan is not a very good choice for evaluation of the prostate gland. For that, MRI pelvis is the gold standard. And tumor appears hypointense on T2 weighted image as compared to the normal gland or other structures which are hyperintense. So this is on MRI, the peripheral zone, which is the most common site for the prostate cancer. And the prostate is divided into two parts, that is central gland and the peripheral zone. And neurovascular bundles are posterior lateral to the prostate gland. And this is how on T2 weighted image, the hypodense prostate cancer has invaded the hyperintense seminal vesicle. So this becomes stage T3B. And there is a well-defined capsule, but on the left side, the capsule has been invaded. So this becomes stage T3A. So in multiparametric MRI scan, apart from T1, T2 image, other images are also taken, which is dynamic contrast images or diffusion weighted images or spectroscopy to have the other features like to detect the change of the grade. For example, the patients who have been put on active surveillance and you take annually a multiparametric MRI scan, and if you see the change of the grade from low to intermediate or high grade, then you can take the biopsy from that and then assign the risk category and treatment can be started. So for additional features, these special images are required. Bone scan is not popular these days because they have been replaced by PSMA PET scan, which the utility of PSMA PET scan is that it may detect the disease at locoregional or metastatic site at low PSA level with a very high sensitivity and specificity. And another thing is the life expectancy, because life expectancy is very important parameter to decide the management protocol. And you have certain tables like Social Security Administration table, you have WHO life tables or Memorial Sloan Kettering life expectancy tool, and you just fill the values, you get the expectancy. So now we come to the treatment part. So in case of unfavorable intermediate risk prostate cancer with a life expectancy more than 10 years or patient is symptomatic, so surgery and radiotherapy both are equally effective. Surgery is done in the form of radical prostatectomy with pelvic lymph node dissection, and if the high risk factors are present, then post-op radiotherapy is given. And the second choice is image-guided intensive modality radiotherapy or radiosurgery with a short course androgen deprivation therapy. But if the life expectancy of the patient is less than 10 years or patient is asymptomatic, you can either give image-guided radiotherapy or radiosurgery with a short course of androgen deprivation therapy in the form of LHRH agonist or LHRH antagonist, or patient may be put on observation also. In high risk and very high risk prostate cancer with life expectancy more than 5 years or patient is symptomatic, in that case, image-guided IMRT or radiosurgery along with the long course androgen deprivation therapy for 3 years is given. And in very high risk cases, abiraterone may also be added for good results. But if in high risk and very high risk cases, if the life expectancy is less than 5 years or patient is asymptomatic, patient may simply be put on observation or androgen deprivation therapy may be given, or IgIMRT or radiosurgery can be done. In regional risk group stage 4A prostate cancer with life expectancy more than 5 years, or patient is symptomatic, then external beam radiotherapy along with androgen deprivation therapy and abiraterone are used for optimal results. But if the life expectancy again is less than 5 years or patient is asymptomatic, either observation or ADT may be done. So surgery. Surgery is radical prostatectomy with bilateral extended pelvic lymph node dissection. And in this case, there is complete removal of the prostate and surrounding capsule along with seminal vesicle, ampulla, and vas deferens. And these are three approaches: open radical prostatectomy, laparoscopic, or robotic. So robotic radical prostatectomy is the treatment of choice because it leads to less bleeding, there is less hospital stay, there is preservation of the distal urethral sphincter, so less chances of incontinence, and less damage to the neurovascular bundle. Now, radiotherapy can be definitive radiotherapy, it can be post-operative, it can be salvage radiotherapy. Salvage means after radical prostatectomy, PSA has gone down to almost 0, and then it has started rising again, and it has crossed 0.1 nanogram per ml. In that case, if the radiotherapy is given, this is called salvage radiotherapy or palliative radiotherapy. So if you are giving IgIMRT or radiosurgery, first you insert the gold fiducial markers, two on the lateral side, one at the apex, which are used for real tumor tracking. You can also use perirectal spacer, which is a material inserted between the prostate and the rectum, so that the rectum is pushed posteriorly and there are least chances of radiation-induced prostatitis. Brachytherapy may also be added with EBRT if you want to escalate the dose in specific area of the prostate gland. So in radiosurgery or IgIMRT, the beams, they take multiple angles and ultimately the prostate gland is ablated with the minimal dose for the surrounding normal tissues and with minimal complications. This is how it is done in a department. For IgIMRT, that is image-guided intensive molecular radiotherapy, CHIP protocol is the gold standard in which 60 gray 20 fraction 4 weeks are given with 5-year biochemical failure-free survival of 90%. And in radiosurgery, Stanford University protocol is most famous, in which 36.25 gray in 5 fraction is given to the whole prostate, and 40 gray in 5 fraction is given to the focal hypodense area with 5 millimeter margin as simultaneous integrated boost. And if you see in radiosurgery, the results are excellent and only grade 1, 2 GI or GU toxicity have been reported with no grade 3 or 4 toxicity. If you boost after IgIMRT, then single fraction of 15 gray is given as per RTOG 0924 115 trial, and it is given by high dose rate brachytherapy machine. And brachytherapy can also be used as a salvage treatment after definitive radiotherapy when there is biochemical relapse. In that case, 30 to 32 gray in 3 to 4 fraction is given with 5-year biochemical relapse survival of 70%. And if you're using radiotherapy after radical prostatectomy, if the high-risk factors are there, then 52.5 gray in 20 fraction 4 weeks is gold standard these days. Now, for androgen deprivation therapy, various options are LHRH agonist with anti-androgens or LHRH antagonists. So among LHRH agonists, we have goserelin, leuprolide, triptorelin or hysterin, out of which leuprolide is most commonly used, 22.5 milligram intramuscular every 3 months. But LHRH agonists, they cause testosterone flare because of the agonistic action. So you used to combine them with anti-androgens like bicalutamide or enlutamide or flutamide for initial 2 weeks. And after that, the medical castration takes place. But if you want to avoid the androgen flare, you can directly use LHRH antagonist. Among them are the dagralix and the relugolix. Relugolix is oral preparation 40 milligram once a day. Now, in M0, M1 castration, say after surgical or medical castration, if the PSA starts rising again, this is called castration-resistant prostate cancer. If this is the situation, you calculate the PSA doubling time. If the PSA doubling time is less than 10 months, you can use secondary hormonal manipulation in the form of eplutamide, darolutamide, or enzalutamide. These agents basically block the androgen receptors on the prostate gland, as well as these inhibit the migration of androgen receptors from cytoplasms into the nucleus. So with good results. In advanced prostate cancer, after failure of multiple hormonal manipulation, you can use the chemotherapy also. And docetaxel and carbadisetaxel are the most commonly used chemotherapeutic agents along with steroids in prostate cancer. If patient has BRCA2 mutation, then targeted treatment in the form of PARP inhibitor, that is olaparib or niraparib, can be used, and these can be combined with enzalutamide or abiraterone. Now, Sipulicil T is a recently introduced vaccine in the prostate cancer. It is PSMA-based vaccine. It is used only for asymptomatic or minimally symptomatic patients with no liver mets and life expectancy more than 6 months and ECOG performance status 0-1 with minimal side effects. So this is quite effective. And if, say, the patient has mismatch repair gene or MSI-H or high tumor mutation burden, that is more than 10 mutation per megabase, in that case, PD-1 inhibitor, that is programmed death-1, which are present on the T lymphocytes, which can be blocked by pembrolizumab. So ultimately, T lymphocytes becomes hyperactive and kill the tumor. So this is sort of immunotherapy with manageable side effects. And this is recently introduced radioactive immunotherapy, that is lutetium-177, PSMA-167. This is basically a beta-emitting radionuclide, which selectively binds to the PSMA receptor on the prostate cancer cells in patients with PSMA-positive prostate cancer. The dose is 200 millicurie every 6 weeks for 6 cycles with manageable toxicity. So to conclude, the treatment of prostate cancer is decided by risk category, which is assigned on the basis of clinical stage, serum PSA level, and Gleason score. In unfavorable and intermediate risk, surgery and image-guided radiotherapy, along with short-course androgen deprivation therapy, are equally effective. In high-risk and very high-risk prostate cancer, image-guided radiotherapy or radiosurgery plus long-course androgen deprivation therapy is the treatment of choice. Abiraterone should be added to radiotherapy plus ADT in very high risk and stage 4A prostate cancer for optimal results. In metastatic castration-sensitive prostate cancer, ADT in the form of LHRH agonist or antagonist with abiraterone or enzalutamide are used. In metastatic castration-resistant prostate cancer, secondary hormonal manipulation in the form of newer agents like apalutamide or darolutamide are used. Chemotherapy like docetaxel and cabazitaxel along with steroids are used after failure to multiple hormonal manipulation in both castration-sensitive and castration-resistant prostate cancer. Spilucicil T, PD-L1 and PD-1 inhibitors, PARP inhibitors, and lutetium PSMA are advanced form of immunotherapy and radioimmunotherapy in advanced prostate cancer. Thank you very much. Any questions anybody wants to ask?
Thank you for your informative presentation, sir. Now I'd welcome Dr. Niket Verma, Assistant Professor, Department of Medicine, AIIMS Bathinda, to present his topic, Breaking Bad News in Hospital.
A very good evening to everyone. First of all, my gratitude to Dr. Vitul Gupta sir and the organizing committee for giving me a chance to speak at this prestigious event. The practice of medicine, remember, this is a golden statement to live by. There is no greater opportunity, responsibility or obligation that can fall to a lot of a human being other than becoming a physician. And in the care of the suffering, the physician needs technical skill, scientific knowledge, and human understanding. Tact, sympathy, and understanding are expected of the physician, for the patient is no mere collection of symptoms, signs, disordered functions, damaged organs, and disturbed emotions. We must remember that the patient is human, fearful, and hopeful, seeking relief, help, and reassurance. Now, if you look at this painting from many, many years ago, this is actually a painting called The Doctor by Luke Fildes, which depicts the caring relationship between a physician and the patient. So even if the doctor or the physician is unable to do anything to save the life of the patient, which in this case is a small child, at least the doctor is there, with empathy, with sympathy towards the patient, and at least to share the pain, if not anything more. So very good afternoon or a good evening to all of you. I'll be speaking today on breaking bad news. My name is Dr. Niket Verma. I'm from the Department of Medicine at AIIMS Bathinda. Now, as a doctor, we do face many situations where we are forced to, or where we are obliged to, I would say, break certain diagnosis or certain facts to the patient that may not be something that the patient has expected, even in their wildest imaginations. So we'll start with definition. I mean, how do we define something that is a bad news? Now, bad news need not necessarily be only a diagnosis of a disease which is incurable. It is any news that can drastically or negatively alter the patient's view of his or her future. Where there is a feeling of hopelessness, there is a risk of upsetting the established lifestyle, or where there is a threat to psychological or physical well-being. In the case of our government setup, many patients, even if they have to buy medicines or go in for a treatment that costs a lot, even that can be a very bad news for the patient. So it is news that results in cognitive, behavioral, or emotional deficits in the person who was receiving the news. So it could be revealing a serious psychiatric diagnosis, which may require institutionalization. A patient who is told that he or she is HIV positive, even though we have treatment that can prolong the course of the disease, but still it is a bad news. Or a couple who are told that they may not have children, so a diagnosis of infertility, for example. So bad news is not only a diagnosis of, let us say, a malignancy which is incurable. It can encompass a wide range of things. The common denominator we must remember in bad news is a message that has potential to shatter the hopes and dreams leading to the very different lifestyle than what is currently being experienced by the patient. So overall, it has an impact on the day-to-day life that can have profound impact on the human psychology. So it does not only include a situation of death, for example. It can also, be a case of disease recurrence, the spread of a disease beyond the organ initially involved, or the failure of treatment, the presence of irreversible side effects, or the issue of discussing palliative care and resuscitation. So it's closely bordering a lot of ethical issues in medicine where we have this issue of breaking bad news. Let us take an example. Mrs. E is a 36-year-old woman with 3 young children, and she has been referred to a doctor, let's say Dr. Z, a young female surgeon, for an opinion about the treatment of a lung mass that her primary physician strongly suspected of being a malignancy, but hoped that Dr. Z could offer better treatment. Now, Dr. Z has reviewed the pertinent studies and concluded that Mrs. E has metastatic inoperable malignancy. So the way Dr. Z reacts to these unsettling thoughts is with detachment, with aloofness towards the patient. And the patient receives a very blunt and a very factual opinion that your doctor was absolutely right. The studies show that you have an advanced lung cancer. It's inoperable, incurable. There is nothing I can do for you. You can see a medical oncologist to determine whether he or she has anything to offer. I know several in the town. And I have more appointments, or I'm a busy doctor or busy physician, so we'll meet again later whenever I have time. On hearing this, the patient bursts into a tirade exclaiming, I came all the way here for a second opinion, but more than that, I came here looking for some hope, some positivity in this very dark tunnel that I've been thrust into. So how dare you stand there and tell me these results? I mean, I know these results, I'm an educated person, but are you aware that I'm only 36 years old? I have 3 small children, no relatives, no parents, no in-laws to look after them. What exactly has the doctor done wrong? If we look at the issue of medical ethics, we talk about the concept of autonomy. So the patient has the right to the doctor is obliged to inform the patient of the complete diagnosis. And the patient has the right to decide the course of treatment, discuss it with the doctor and decide whether or not she will take any treatment and what course the treatment will take. So what exactly has the doctor done wrong to upset the patient so much? What could she have done differently? To understand that, we obviously know the concept of empathy, where we must put ourselves into the patient's position. It's easier said than done. Obviously, it's difficult to put yourself in the position of someone who's just heard the diagnosis of an incurable malignancy, for example. So let us first discuss another important point. Whose information is it exactly? Before we start putting ourselves into that, into the shoes of the patient, whose information is it exactly? Now, the issue of whom to tell the bad news has been debated for many years, and you will still find a lot of doctors who will say, it's not correct to inform the patient. The patient may it may have a very deep psychological impact on him or her, so it's better we tell the relatives. You will face a lot of relatives who will say, don't say this in front of our father or our mother, unke samne mat baat kariye is bare mein, wo ye jhel nahi payenge, they'll not be able to bear this sort of news. So you tell them this is something, it's a serious thing and we are doing our treatment, or aap theek ho jayenge. So it's been a common practice in lots of areas in our country, due to maybe cultural factors or whatever, that the relatives are given a large amount of information and confidential things are left out from when you're talking to the patient. So you don't tell the patient certain confidential information, you withhold it from them. So what are the skills required when we talk about breaking bad news? Obviously you need knowledge, you need skills, you need attitude. But what you really need is communication skills. Now, it's a very important part of our new curriculum, the competency-based medical education curriculum, which came in 2019. And it is emphasized as a longitudinal factor starting right from day one in medical college, where communication is emphasized, the art of speaking to a patient. In our department of medicine, we try to start the first clinical posting of students with the same thing. How do you speak to a patient and how do you extract useful information from a patient in the clinical classes? So we always start from that. We never start from theoretical or clinical direct bombardment of knowledge, but rather the art of speaking to a patient and gaining knowledge from the patient. So whereas a student of first year learns that the cadaver is the first teacher, when they come to us in medicine posting in second year, we teach them that the patient is your second teacher. So learn from the patient. Effective communication skill can have a lot of components. It can be written, it can be verbal, non-verbal. There is active listening involved, so you must know when to keep silent and listen to what is being said. There is trust between the patient, a trust built on the bedrock of confidentiality, where you can tell the patient the correct diagnosis, the patient can tell you the correct symptoms. There are personal connections, there is cultural awareness, there is compassion and empathy, and of course there is presentation skills and patient education. So there can be serious miscommunication, serious problems if the facts are disclosed improperly. And a complex task, it's a complex communication task which requires expert verbal and non-verbal skills. The staff should avail of interpreting services, remember, if there is a language barrier between the doctor and the patient. Now, how much information does a patient really want? So the debate about this has also been going on for many, many years, about how much level of truth has to be told to the patient. Yes, you have told the diagnosis, but do you really need to tell probably the lifespan that is remaining unless and until the patient has asked for it? I mean, as a doctor, are you obliged to tell everything even though the patient is not interested in hearing it? Or are you supposed to wait for the patient to ask any questions? So while doctors and professionals now increasingly share information, it has been the practice, like I told you earlier, to withhold certain parts of the information. It was believed to be in the best interest of the patient's psychology, probably. Now, patients have been shown to be increasingly wanting additional information regarding the diagnosis, the chance of cure, the side effects of therapy, and a realistic estimate of how long they have to live. So this is all, the studies have been done and it's all scientific information. The doctor, the patients want the doctor to be compassionate, to be honest, to be caring, and to give some sort of hope. Even if it seems hopeless, someone who gives even a little glimmer of hope is perceived as a better doctor than someone who gives a very hopeless diagnosis. So to be told in person, to be told in a private setting with full confidentiality, at a pace which the patient sets, in a language that the patient can understand, at a time which is convenient for the patient, and if they wish, in the presence of a supportive person or a relative or a friend. So the way to discover this is to basically ask the patient what they really want to know, when they want to know this, and to do it in an atmosphere that encourages an honest question answer. They should be given information, whatever they want to ask. They should be, you should reply to that, and you should give them whatever information they seek. Honest sharing and evaluation of probabilities will lead to development of mutual trust and mutual confidence between the doctor and the patient, and will provide a foundation for a strong doctor-patient relationship. If the patient chooses not to be informed, remember, again, the concept of autonomy, you have to respect that. So even if it's in the patient's best interest, but the patient chooses not to be informed, then many countries do follow this concept. If the patient says, no, I don't want to know the results of my tests, then you are not obliged to tell them anything. Now, why is breaking bad news so difficult? Because it's an extremely stressful experience, not only for the patient, but also for the caregiver, for the doctor, for the health professional. And this stress can result in a reluctance. There is a reluctance among the postgraduates, among the undergraduates to deliver any sort of bad news, because they all fear some sort of very negative response from the patient. So they avoid discussing poor prognosis, they avoid conveying unwarranted optimism, and this process has an adverse effect on the psychology of a doctor as well. This is particularly evident when a doctor lacks experience and there are limited options for treatment. So clinicians are found to be uncomfortable discussing the prognosis and possible treatment options. There is uncertainty about the patient's expectations. There is a fear of violence from the patients or their relatives. Many of them have come with a lot of hope, and they get very angry when you say that there is no hope at all, and there may be some sort of violent encounter with the doctor. And they are not prepared to manage the patient's anticipated emotional reactions. So probably an outburst of emotion, crying, feeling absolutely depressed. Maybe we are not really, geared up to deal with that kind of an emotion. And then you have an embarrassment. Probably earlier you gave them a very positive outlook. हाँ जी, 100% आपको ठीक करके भेजेंगे. And suddenly it's come down to 10%. Then there is an embarrassment also that I promised and I'm not able to live up to the hopes of the patient. So you do not have to be rude. You do not have to make fun. You do not have to convey unnecessary optimism. But then what do you have to do? That's the whole issue. How do you break bad news? So we must keep in mind the ethical aspects of medicine, first of all. We spoke about this earlier. And the 4 pillars of medical ethics, which includes beneficence, non-maleficence, justice, and the very important pillar, that is autonomy. So the patient decides. Now, 50 years ago, most physicians were able to avoid discomfort by concealing the truth. Now it has been seen in a lot of studies that doctors are, from their side, very open to discussing every treatment option, every prognosis, howsoever poor it may be. And since then, it is gradually becoming the norm that you must respect the patient's autonomy. So autonomy can have a lot of aspects. One is ownership. So the patient must take ownership of his or her treatment. There is strength. The patient will derive strength from a doctor who's, giving them a very realistic outlook rather than from someone who's giving them a very, there is absolutely no hope, but you're giving false hope. So that is not required. Motivation, when you can discuss treatment options, whatever is convenient to you, you can decide which treatment option to take. And of course, building up on a very strong foundation of a doctor-patient relationship. This is all discussed in the ATCOM module, which was also released along with the CBME, and it is being implemented in most of the colleges in our country. It's a longitudinal program again, spread over the entire duration of MBBS, starting again from the day students enter, and ATCOM stands for Attitude, Ethics, and Communication Skills. Now, who breaks the bad news? So doctors historically have been tasked with breaking bad news, but it can be done by any healthcare staff member. Remember, we all work in a healthcare team as long as they are properly trained. There has been a renewed interest on training the doctors and the healthcare professionals. And for this, you need to educate them. So healthcare professionals education is moving now from a large group setting to a small group setting to maybe a simulation-based teaching learning session in a skills lab, an in-situ simulation setting in the emergency setup, or a real-life immersive setting using augmented reality. Look at this. This is a simulation setting, which is being done in a skills lab, and students are being taught how to break bad news to a patient in a skills lab setting or a simulated setting. Again, it can be an in-situ simulation, which can be done in the emergency department where the action is, and the students can learn in a very real-life setting how bad news is to be broken. These are the reactions that you can expect, ranging from shock, horror, and anger to disbelief, denial, or rather even colluding, and trying to force the doctor to change their opinion, listening to only the positive parts which you want to listen to. So the very important part is, why do you need a strategy to disclose bad news? Because the way a recipient receives bad news can have a lasting negative effect on the patient. So delivery of bad news can have a long-time hostile impact, not only on the patient, but also on the caregiver. So there are three models which you must keep in mind: non-disclosure, full disclosure, and individual disclosure. Now I'll cut my presentation short, so we'll not go into great details about these three models, but we must remember non-disclosure is bad. Full disclosure may not be the correct thing to go for. What we really need is individual disclosure. It's tailored as per the needs of the patient. So each patient, each physician, each situation is different and is flexible. Please remember that. So the underlying assumption is in an individual disclosure that people are different and it takes time to absorb and adjust to the bad news. Please give them time to absorb and adjust to the news you've given them. There's a partnership between you and the patient and the other caregivers. Please respect that partnership. Let there be a shared decision making. There are lots of advantages of non and full disclosure, but the biggest advantage of individual disclosure is it is tailored to the needs of the individual. The disadvantage is it is a time-consuming process, and we may not be trained for this particular model, so we tend to keep continuing either with non or full disclosure. So this appears to be the ideal model, but are we really following it? I don't think so. We need to move from non-disclosure towards individual disclosure. We need to avoid going on to the stage of full disclosure, where the doctor-patient relationship is of a partnership and the management style is a joint management. You all heard about this model, so I'll just sum it up in just a short while. The Spikes protocol. The Spikes protocol talks about the proper setting, where you must keep in mind the privacy, you must involve significant others as per the wishes of the patient. You must look attentive and calm. Please switch off your phones, leave your phones outside when you're delivering bad news to the patient. The perception is, before you tell, you must ask what they perceive. Aapko kya samajh mein aaya abhi tak, from all the tests we have done, from all the diagnostic investigations that are done, what do you feel are we really, going towards discussing? What do you think was going on with you? What do you think is wrong with the particular part of your body? What have you learned so far? What have the other doctors told you? So before you tell, you must ask. Then is the very important stage of invitation. So although most patients want to know all the details, it's not always true. Every patient may not be wanting to hear their diagnosis. So before you start blabbering everything, please ask the patient for permission. Let them decide whether they want to know anything or not. Are you the kind of person who prefers to know all the details that's going on? How much information would you like to give me about your diagnosis? These are good questions to work on. Then there is knowledge. Give your patient a warning, a small warning in the beginning. Unfortunately, Mr., Mrs., whatever, I have some bad news to tell you. It's not a very positive thing, but please bear with me, I'll explain it to you. Use language that the patient understands, avoid technical scientific jargon, give the information in small chunks and regularly take feedback from the patient, whether they have understood what you're speaking. Then there is empathy. We've spoken about this. You've attended plenty of sessions on this issue. So you need to put yourself in the patient's place. It's difficult to do that. It's easier said than done. But respond to the emotions in a humane manner. That's the whole thing. So listen for identify the emotion. Tell the patients it's okay. It's okay to feel sad. It's okay to feel angry. It's okay to deny all the diagnosis that I'm telling you. It's all right. But make a connection, an emotional connection with the patient. And then summarize and discuss future strategies. Again, as per the wishes of the patient, at the pace of the patient. There are other strategies, we'll not go into detail. So there is an ABCDE, and there is a 6-step protocol, and there is a breaks protocol. But the commonest one that we discuss in undergraduation as well as in postgrad is about the spikes protocol. That is a setting, perception, invitation, knowledge, empathy and emotions, and summarizing. Now the take-home message from the session, breaking bad news is a distressful situation. It's distressful not only for the patient, but also for the caregiver or the physician. Without a plan for addressing these issues, without a proper strategy, without a proper protocol, you may attempt to downplay the bad news, reveal only bits and pieces of the information just to avoid going into details. The task will never be easy, but then we are doctors. We must remember our task is never easy. So having a plan of action will be very supportive, will be very helpful. And discussing things with the patient frankly will help them pass through this difficult time with your help. In summary, applying the different models in talking to patients and their families about the diagnosis means addressing not only the impact, but also about not only the future, not only the present, but also about the future course of the disease. These are my references, and I thank you all, and I leave you with this wonderful quote from Robert Buckman that says, "The task of breaking bad news is a testing ground for the entire range of our professional skills and abilities. If we do it badly, the patients and their family members may never forgive us. But if we do it well, then they will never forget us. So let us aim that they never forget us and we are able to break bad news in a humane manner." Thank you so much for your patient listening.
Thank you, sir, for your fantastic presentation. Now I call upon Dr. Manuja, Associate Professor, Emergency Medicine, GGS Medical College, Faridkot, to present her presentation on topic Poisonings, General Management.
नहीं मेरा लैपटॉप लेके आऊँ अभी दिख रहा है अभी भी दिख रहा होगा छोड़ दो नहीं छोड़ दो प्रेजेंटर व्यू निकाल दो बंद कर दो इसके बाद क्या बोल दूँगी ठीक है अब तो नहीं आ रहा Well, good evening everybody. Seeing that most of you are already seem to be poisoned with all the, academic fees today, isn't it? Overdose ho gayi hai sabko. So, we'll start with approach to poisoning. What should be the general approach to poisoning, especially when the patient comes to emergency, fine? And our objective will be that by the end of the lecture, we should be able to describe like what should be our approach to assess the patient, how to resuscitate and stabilize the patient when a patient comes with suspected poisoning, and what should be the physical findings, physical examination findings. Just a minute. What should be the physical examination finding associated with various toxidromes and the antidotes and treatment required for poisonings along with the indication, fine? So what do you think, like what is poisoning actually? Anybody, any takes on that? Okay, poisoning is actually any illness or any unwanted side effects which is caused by exposure to any toxic substance. I mean, toxic kab pata chalta hai? When we get any untoward like signs, symptoms. So why not call it only like having exposure to any toxic substance? Exposure means that you may not have the unwanted side effects. So we call it poisoning only when a patient has illness caused by the exposure, fine? And it can be mostly when a patient presents, most of the time it is with any overdose or any exposure to any recreational drug, something gone wrong, any alcohol intoxication, or sometimes it may be like occupational exposure, like with pesticides. And then it can be environmental exposure. Patient may do this with the intention of deliberate self-harm, like suicidal attempts, or accidental ingestion, like we often see in the pediatric age group. Often जैसे इंडिया में है ना, वो खाली डिब्बा तो फेंकना ही नहीं है, तो उसमें कुछ भी स्टोर करके रख देंगे, तो उसके बाद वो बच्चा क्रॉल करता हो जाता है और उसको खा लेता है, ठीक है? So true incidence is unknown, but then it is the very common cause of an emergency department visit. Fine. And why it is so important for emergency department? Because we are the first contact with hospital for anybody making an unwanted visit to hospital. Wanted भी आते हैं, भाई लोग AIIMS घूमने भी आते हैं, ठीक है? 28-year-old man found on a ground in a field, brought to emergency because he was unresponsive, he had white powder on his face and clothing, and he started vomiting during the examination. So, if it would have been, apart from the seniors in the front, I'm in filled auditorium, I would like to ask you about your approach and assessment and the management of this patient. Well, to proceed further, anybody who passed along with me, they would say, ma'am, we will go in for GI decontamination with nasogastric lavage and activated charcoal, whole bowel irrigations, optimize the supportive care. So, do you all agree with me? Pardon? Pardon, sir? So partially you're right, but I still disagree with that. Fine. So my objectives, as you said, it is part of resuscitation, prevention of further exposure, enhanced elimination, and then antidote therapy. But for initial stabilization, what do? My first thing would be to talk about ABC. भाई graduate हो गए, post graduation कर ली, अपनी practice आरंभ कर दी, तो अभी भी बातें हम लोग ABC करते हैं, ठीक है? So my first take on that would be to check with the airway. First thing to check for any patient would be to see for the patency of airway, whether the patient is able to maintain the patency, whether the saturation is being maintained. Agar nahi ho rahi patency, तो my first duty is to secure the airway and see that it is in the right place. Fine. Support the breathing of the patient and then start with the, at the same time, I have to take with the IV exits, start with the fluids, support the circulation and the hemodynamics, then check for the disability of the patient, perform the neurological survey, and the mandate under everything is all this has to be done in parallel, not in series. Nothing in medical, हम लोग याद करने के लिए जो भी करें, nothing is done in series. ऐसा नहीं है, एक चीज़ करेंगे, ये खत्म हो जाएगी, तभी दूसरी चीज़ करेंगे. Of course, we work as a team in emergency, So everything has to be done in continuation, and never forget to check the glucose of any of the patients. Okay, so now we again come back to the previous one. So now we consider the GI decontamination along with, we optimize the supportive care, and we administer the available antidote. So how do you decide which antidote has to be given? How should we support it? ABCD to kar liya. Uske aage kya? We very well know. We put on our thinking caps. After all, we studied so much. Satoskar, Tripathi, सब कुछ तो पढ़ लिया था. उसमें से कुछ ना कुछ तो निकाल ही लेंगे. कहीं ना कहीं तो उसको fit कर देंगे और antidote भी दे देंगे. Does it seem to be that easy? If it was that easy, Miss Rawling would not have been writing about sorting hats. We remember the approach taken by the sorting hat. Okay, they put the sorting hat on the new child. The sorting hat used to say, okay, you are brave, you can think about, so I put you in Greyfinder or I put you on in Slytherin. Similarly, we think about, we put a sorting hat and we named our sorting hat toxidromes. So toxidromes is basically the clinical signs and symptoms associated with different classes of toxin, fine? And it is mostly based on the autonomic effects. We rely on the observable findings, like what about the eyes, skin, secretions, and vital signs. And this allows us a rapid narrowing of the differentials. So these are the traditional toxidromes we use: sympathomimetic, anticholinergics, cholinergics, sedative hypnotics, and the opioids. So for sympathomimetics, just to make it easy, we made it into a tabular form. The heart rate becomes fast, it increases, blood pressure becomes high, the cardiac rhythm changes, most often we have tachyarrhythmias, then the respiratory rate and temperature, it may be normal or it may increase. Eyes becomes mydriatic, skin is like diaphoretic mostly or normal, then secretion may be normal, fine? And similarly for anticholinergic, there's unopposed sympathetic tone and there's loss of cholinergic innervation. So heart rate, blood pressure, cardiac rhythm, this may all increase, becomes fast. Respiratory rate may become remain normal. Temperature becomes high and eyes become mydriatic with drying of skin and secretions. And the mnemonic is, I mean, this was my favorite mnemonic. कुछ और याद आए नहीं आए anticholinergic, ये तो हमेशा याद रहता था. Mad as a hatter, blind as a bat, red as a beet, hot as a hair, and dry as a bone. ठीक है? And which drug we use to remember all this? Atropine. And you all know why it is known as atropine. It was derived from the plant Atropa belladonna. And belladonna, पता है उसे क्यों ऊपर लगा था? It was used in the earlier times by the ballerinas to give that beautiful eyes look, wide open. Cholinergic toxidrome. Now it is heart rate becomes slow, blood pressure becomes low or normal, cardiac rhythm becomes brady, respiratory rate becomes less, temperature may become less, eyes become miotic, totally opposite. Skin is like diaphoretic, secretions are copious. Sabse badi problem, especially in agrarian society like ours. And these are the mnemonics, sludge and dumbbells. Kis mein dekhte hum sabse zyada? Organophosphorus poisoning mein, when they come. Then is the sedative hypnotic. Isme aur kuch, like you may not remember the mnemonic, nothing. Just remember that it is just pouring out from everywhere, all orifice. Sedative hypnotics. Sedation is the primary hallmark. And patient is like sleepy, drowsy. Patient may not be able to protect their airway, especially in severe cases. They may be having respiratory depression, but there may be minimal autonomic effects. And there may be some symptoms which we may not be able to explain because of the co-ingestion. Sedative na mostly akele nahi milte. They are mostly like in a combination of drugs. Then is the opioids. Mostly there is miosis and respiratory depression is very common, and if not taken care of at the same time, it may prove to be fatal. So we do a review. We have just tried to summarize all the toxidromes. Fine. The sympathetic, if we see at a glance, if we want to check them, what is the difference? It has been presented in a tabular form together. And then we go on to remember this to the first case we were talked about, a 28-year-old man who was brought to emergency, who was unresponsive, who was found on the ground in the field, and he had white powder, and he began vomiting. So now his vital signs, temperature is like slightly low, heart rate is low, respiratory rate is like fine, BP is fine, saturation is less, and gurgling respirations with pool secretion, that means, and pupils are like 1 millimeter with skin cool and diaphoretic. And so what do we say? I mean, the age got changed while making the slides, but it is the same person. So what do we say? Gurgling respirations with pooled secretions. That means secretions everywhere, isn't it? Pupils 1 millimeter, okay? So it is like bodily fluids were everywhere, cholinergics, and most of the cholinergic exposures are from pesticides. Let's talk about our area, organophosphates. So our management will be, apart from the airway, breathing, and circulation. Okay, we'll talk about the decontamination here for D, and prevent further exposure for patient and for you, okay? And of course, we talked about that we have to go in for early intubation. Then management would be further for high flow oxygen with positive pressure, and antidote would be atropine and pralidoxim. Now, pralidoxim, though it is only suggested nowadays, but it still has to be, it is there in the management part, it has to be continued for the first 3 to 7 days. Second case is about the bottle found on a bed. A 38-year-old man was found unresponsive in the bedroom by the family. And they saw, while they just got him to bring him to the hospital, they saw an empty pill bottle on his bed, but they did not bring it with them. So, and what do you suspect? Well, pill bottle padi thi, to koi na koi to drug exposure hua. So now the pupils are like constricted, skin is cyanotic but dry, and if we see, the main thing here is respiratory rate is 4 and saturation is very less. So that means patient has respiratory depression. The first and fourth thing that comes to my mind after seeing this patient as per toxidrome is opioid poisoning. See, the pupils were pinpoint, respiratory depression was there. Now exposure may have been recreational. Okay, kuch na kuch to tha na, he was found in his bedroom. Management would be again, support the respiration, airway and breathing. Okay, so patient may need intubation, especially because he did not, who don't rapidly respond to the treatment and restore the oxygenation. Antidote would be naloxone and opioid receptor, because it's an opioid receptor antagonist, and dose required is variable. Now it's a very short acting naloxone. So like once you verify, you may have to start with infusion, or you may start the patient on artificial ventilation with the help of ventilator. So slowly, slowly the effect will wear off, and then you can extubate your patient. So the learning objective for today are, like we are able to describe an approach based on the toxidromes for the assessment, stabilization, and we have described about the physical findings associated and the list of antidotes and treatment. So essential principles would be, use the knowledge of toxidromes to narrow the differential. It is not possible to remember the thousands of drugs we know. Abhi hota kya hai? Likhiye, let us associate with religion as is the as we are all primed to do. 33 करोड़ देवी देवता हैं. आपको कितनों के नाम याद हैं? जब कोई मुसीबत पड़ती है तो मैं तो सबसे पहले ऐसे याद कर लेती हूँ, ब्रह्मा विष्णु महेश हनुमान जी, बस हो गया जी. अब 33 करोड़ कौन याद रखेगा? सभी में सार आ गया ना, तो ये 5 टॉक्सीड्रोम याद कर लो, काफ़ी कुछ तो निकल ही जाएगा. बाकी तो ठीक है, गूगल बाबा हमेशा है. ठीक है. Externally decontaminate your patient to protect yourself and them. Aggressive support with, always remember ABCD. प्राइमरी में पढ़ा हुआ कभी खाली नहीं जाता, ठीक है, और छोटी एज में पढ़ा था तो याद भी रहता है. अभी वाली चीज़ें तो शॉर्ट टर्म मेमोरी में ही जाती हैं. Consider decontamination, GI decontamination, give antidotes wherever available and indicated, and try to enhance the elimination. So, अभी इतना करने के बाद आई होप यू ऑल आर डाउन विद द पावर पॉट पॉइजनिंग, और उसका तो कोई मेरे पास एंटीडोट भी नहीं है सजेस्ट करने के लिए. सो एनी क्वेश्चंस ऑन दैट?
Thank you, madam. I must congratulate on your excellent lecture and moreover, your personality. You are the most, you can say, adjusting speaker that you offered. That tell me 7 days before, because there was lot of queries from other speakers कि हमको यहाँ पे time adjust कर दो, यहाँ के पे कर दो. So I am really grateful to you for your flexibility and helping us out to allot these slots to the speaker. And I want to make you permanent faculty for MAPICON for next 5 years. उसके बाद का तो हमको पता नहीं है, पर we are really grateful to you for your flexibility and your offer. So it is really great. Thank you very much.
Thank you, sir, for the honor.
Now, I'd like to call upon Dr. Pankaj Kumar Sharma, Associate Professor, Department of Orthopedics at AIIMS Bathinda, to share his presentation on nutrition and bone health.
Good afternoon, all dignitary and my colleagues. As an orthopedic surgeon, so I mostly believe in bones, not in medicine and everything. And I like surgery, but surgery is not a complete treatment for bone disease. So we have to talk about some medical part also. So let's discuss what is the peak bone mass, calcium and vitamin D, other nutrients and dietary factors which affect the bone health, bone loss, and osteoporosis. Actually, the topic is very big, so we will roam around these 4 or 5 topics or 4 or 5 topics for the discussion. So, what is peak bone mass and when it is happen in our daily routine life? So, what is peak bone mass? It is basically bone mineral density which we count as a peak bone mass, and it is also known as bone quality. And also some study we also take it as a bone loss. And it is mostly, if you think about BMD, that it is directly related to the bone fractures, mostly IT fracture, wrist fracture, and your spine fracture. So there are a number of studies which has peak bone mass age, this its prevalence, etiology changes. We are not discussing here, but we have to know about peak bone mass. There's some quotation about the Professor Charles Dand, which told that osteoporosis is not a old disease; it disease of pediatric population. Why? Because if you are saying that some people is become aging or old, it is not right. The patient become, or the man or woman become old from the intrauterine life, like from the ovary. If you are talking about some patient's entity, it is the aging start from the ovary itself. So the osteoporosis start from the infancy, and it aggravated by the nutrition, bone health, exercises, and other disease or metabolic disorders. So we start from the infancy. Or the peak bone mass is the maximum bone mass achieved in the life, and it is always directed toward a healthy lifestyle during the bone forming years, particularly adolescence. Though after infancy, if you are free from any metabolic disorder or other disorder, then it's come to the adolescence age. And these are nutrition, physical activity, and factors which I already mentioned. So good nutrition with particular attention to calcium and vitamin intake is very important for all the children and in particular growing age. Bone growing age is there 2 or 3 spurts in the life. First in infancy, around 3 up to 3-year-old. Then it is around 10 year, and then the puberty. There are 3 stages which we can found bone spurt. Then physical activity, we have to start physical activity from the very beginning and every phase, like in every age from the infancy to the old age. Then body weight, as you can see in the number of literature that in developing country or even in developed country, in US and Europe, there is increased obesity and mobility nowadays. Then the lifestyle, mostly which is handy, like alcohol and smoking. These both are handy things we can carry out everywhere in our pocket, in our luggage. So these smoking and alcohol are worst thing for the bone health. Then second thing, calcium and vitamin D. It's a very controversial topic that calcium and vitamin D is very important for the bone health. But it is not controversial, it is required. But like in osteoporosis, that means if the osteoporosis is confirmed, then it is not the single role of the calcium vitamin D. You have to take other thing also. So what is calcium vitamin D? These are the key component of bone, and it is in mineralized form in the bone. So up to 9 to 18 years of age should consume approximately 1300 milligram calcium daily. But it is not right because 1300 is not pure form. You have to take calcium in the pure form or different form which is digestible. So it is not rightly saying that 1300 mg is adequate. So sometimes we have to take 2 gram also. Then adequate vitamin D for the metabolism of this calcium. So it is 600 internal unit, but again it is not 600. It depends on the body form, body growth, other disease, other metabolic disorders, and the enzymes level of the body. So I already discussed this thing. So if the patient has like nephrotic syndrome, it is not the same treatment which can be given with vitamin D or calcium. You have to modify the drugs. So it depends upon the body metabolism of calcium and vitamin D. So always plan calcium and vitamin D according to your body and your physical condition. This is peak age of the bone growth, 9 to 13 year and 14 to 80-year-old. And the daily intake is like equal. So it is around 1 to 2 gram of calcium which can be given in these ages, 1 to 2 gram. And upper level is 3 gram. Up to 3 gram you can take easily without any side effect. But if there is some geoparadise in your kidney or liver or something chronic disease, then you have to be measure these calcium vitamin D accordingly. There are a number of trials which shows the use or benefit of these things. But in my practice, if there is some other disorder, there is no benefit of calcium vitamin D alone. So you have to be search out the primary pathology of the bone health, bone disease. Mostly trial evaluate short-term supplementation in healthy children who did not have inadequate dietary intake of calcium vitamin D, and there is good effect. But in longer study, it is very important if longer follow-up. If you are giving calcium vitamin D in proper under controlled way, obviously it is good for the bone mineralization and the fracture prevention. So in India or in worldwide, we are getting old earlier and our longevity is increased. So the old age is increasing and the young age is decreasing. Our average lifetime, I think lifespan is equal or not increasing, but our old age is increasing. So it is very important for the long-term follow-up. Then the body mineral content in children and adult, it is different. So we have to take calcium vitamin D separately for the both. Some random trials evaluate these things. So the doses of calcium and vitamin D is different. It is range. Again, there is some study which includes calcium supplement in 300 to 1200 milligram daily for the 0.7 to 7 year, and no difference in BMD. So calcium vitamin D alone, it doesn't affect the BMD directly. If there is some disorder or some problem, you have to take care of that disorder. And the second thing is physical exercises. If there is no physical activity, these drugs are not effective. Other study which also same the conclusion or meta-analysis, there is no difference in total BMD for the hip, forearm and lumbar spine in children, which are undergone treatment of calcium and vitamin D. So along the calcium vitamin D, we have to take care of other thing also. There are a number of supplement or number of source of food which can be used for calcium, but it depends on your food habits and your social stigmas. Like in India, we are vegetarian or some Jain food. They have to take number of foods for the calcium. But yogurt plain, yogurt fruit flavored, this canned milk non-fat, cheese, collard greens cooked, cheese Swiss, and some fish, tofu, soft. There are a number of things which can be used for the calcium, but mostly calcium comes from the vegetarian food, which is not digestible properly to all people. There is good thing in India like sesame seeds, which can be easily consumable, and it has good amount of calcium. Even 1 tablespoon of tea, it contains around 37 milligram, 88 milligram calcium. So sesame food seeds are very easily available. We can use it by dietitian opinion, with dietitian opinion. You can see in a single unit there per 100 gram calcium available and bioavailability. Actually 60% is the bioavailability of this calcium. So you can take sesame seeds. The second thing, calcium absorption, like I already told that vitamin D is very important for the calcium absorption. So you have to carry out about these calcium absorption. So you have to take care of kidney, liver, and your intestine. The three things which is very important for the calcium absorption. The vitamin D is 4,000 international per day, is average for all the persons in average age and weight. To vitamin D, there are a number of guidelines which include World Health, WHO, International Osteoporosis Foundation, Institute of Medicine, Endocrine Society, American Association of the Clinical Endocrinologist, European Association, and these conclude that the terms of desirable 25 hydroxy D level means vitamin D which is absorbable state set at 30 nanogram per ml and 20 nanogram per ml. So you have to take recommend dose between the 600 and 800 for the International Osteoporosis and 600 to 2000 by the European Society. So it is around 800 to 1200. You can take this type of dose or supplement. But again, there is different target population. So it depends on variation there around the mean, like race, calcium intake, renal functions, body mass index, polymorphism, key protein. So there is no fixed dose of vitamin D and calcium. So vitamin D also you have to evaluate according to your variation of these things, like your ethnicity, race, what your foods and calcium intake. If you are not taking proper calcium, there is no role of vitamin D to mobilize it. Then individualized requirement for the vitamin D supplementation. So there are a number of things like sunlight exposure, skin pigmentation, baseline vitamin D level, intestinal absorption rates, age, type of vitamin supplement, genetic variation. So there are a number of things which can be accommodated for the vitamin D absorption. Like in India, we are not exposing sunlight nowadays because the sunlight is very sharp or very not good for the sun for roaming around. But in foreign country or where the temperature is not much more, they expose themselves in sunlight. So in India, you have to take some kind of supplement in spite of sunlight. This is some theoretical, what is the levels of blood or vitamin D. I'm not going thoroughly. Then source of vitamin D. Again, the salmon pink. Actually, vitamin D is fat soluble, so mostly non-vegetarian origin. So salmon, mackerel, canned milk, milk with fat, milk non-fat, cornflakes, and cereals, some cereals. So we can get some good vitamin D in these foods product. Then other nutrition, these are the most common calcium and vitamin, and then other nutrition which also affect the bone health, like vitamin K. Dose is 120 microgram per day for man and 90 microgram per day for women. And this is basically enzyme. It acts as an enzyme. So used in body for the different metabolic activity of the absorption of vitamin D and calcium and other things. So we can get easily vitamin K from the green leafy vegetables, spinach, collard greens, lettuce, and scallions. So these are very easily available in India also. So we have to take vitamin K with the other supplement. Again, source is turnip greens, broccoli, Brussels sprouts, spinach leaf, lettuce, cabbage, soybean. So it is mostly vegetable origin. So vitamin K we can get from the vegetable origin. But mostly people are nowadays not in favor of the green vegetables. So this is the vitamin K deficiency also in growing age and old age. Then phosphorus, it can be get by the milk, meats, eggs, legumes. And in processed food as a food additive, nowadays we also include number of foods which has phosphorus. In soft drink, it is in phosphoric acid. So phosphorus is also good for the bone health. Actually, it is also like a enzymic activity. Then magnesium, dose is around is not actually 350 milligram per day, but it can be varied. Source is green leafy vegetables, whole grains, seeds, nuts, seafoods, beans, and some dairy products. Source of magnesium you can tail mix with chocolate chips, nuts and seeds, spinach, beans, black, muffin oat bran, beans navy, rice brown. It is also vegetable origin. So magnesium we can also get from the vegetable origin. What is the side effect, or what is the, if you are taking more magnesium than the normal, then it can cause diarrhea, nausea, cramps, dehydration, and acid-base imbalance. So it is mostly affect the muscles and the muscular system through the intestine. So if your kidney is not going proper, so there is hypermagnesemia. And if you are not taking proper, or your digestion is not proper for magnesium, then you can get hypocalcemia, osteoporosis, heart diseases, high blood pressure, and type 2 diabetes. But these are not single factors, there are number of factors for that, the disease. Then the lifestyle, nowadays we are taking carbonated soft drinks. That is not good for the bone health. It actually displays the more nutrient from the body, and daily intake of calcium is increased or reverse. So the carbonated drinks are not good for the digestion of the calcium vitamin D. Then high soft drink consumption in the adolescents population contribute to the low calcium intake, because we are not taking proper food if you are taking the junk food and these drinks. Like calcium and iron are not additive effect. So like if you are taking calcium and iron along with milk, so it is not digestible. So like soft drink or cold drink we are using, it is reverse of calcium intake, because it decreases the absorption of calcium due to some antacid effect or some kind of acidity, or the different kind of acidity which is not required for the digestion of this food. Then phosphorus viability is also, the drinks affect very much. And in old age, if you are taking soft drinks or these kind of drinks, it is affected much more than the adolescence. So if you are getting old, then you have to leave these drinks. Means if you are getting pain, muscular pain and body parts pain, then you have to leave these kind of drinks. Then caffeine intake, it is very common, like in form of coffee, tea, theban. So in India we have a habit to take coffee and tea very frequently. It also deteriorates the BMD. So direct effect, it has both effect, direct and indirect. So directly effect, it also affects the absorption, and indirect, it also displays the good habits, good diets. Then high acid or alkaline diets, which include in protein, dairy and grains, increase calcium excretion. So if your body fluids are alkaline, so it is good for bone health. But if you're getting more acidity in your food or like high acid, then it is not good. So you have to maintain your pH in your body fluids with the adequate intake of these diets like protein, dairy, and grains. So you can't intake inadvertently. You have to take these with proper guidance. So these are some food which have effect on the BMD and your bone health. This is dark leaf vegetables is very good for the bone health if you are vegetarian. Then bone loss is also indirectly the not growing bone or properly health of bone. So bone loss. Nowadays, bone loss is very important. Like we have a tool, frac tool, which is fracture-related tool for the osteoporotic bone. So it is used for the prevention of osteoporosis, and the pyramid shape of osteoporosis. The peak is the fracture, or which start from nutrition, physical activity, and the fall prevention. So it is some preventive part of CFM department. So bone loss is also a measurement. So we have to take out physical activity, food, and pharmacotherapy. There's a number of things which affect the bone loss. There are a number of factors which is underlying diseases, hormone diseases, age, body weight, calcium, vitamin D intake, physical activity, family history, alcohol consumption, cigarette smoking. They are common factors which can be found anywhere, any age group. Osteoporosis is very common and very wide topic, but I am not taking more time for this thing. But it directly measured by the BMD or your other things which have DEXA scan and dual. Nowadays, ultrasound guided scan also, CT guided scan also. You can measure the osteoporosis measurement. So there are a number of things which have definition. Is the WHO definition is that osteoporosis decrease in the bone mass 50% and the bone quality 50%. And there are a number of measurement like BMD and Z score and T score. But it also affected by the other thing also. Like this is mostly in the aging population. In like there is bone disease, like metabolic disease. You can't predict the osteoporosis by this definition. If there is minus 1.1 T score, or is osteopenia in normal population, but in metabolic disease it is osteoporosis, because there are a number of things also. So there are a number of factors for osteoporosis. Lifestyle and osteoporosis, it is very important. We are only treating the pain and the calcium deficiency, but not the muscle deficiency. So inactivity is the most common cause for the osteoporosis, inactivity. So nutrition, physical activity, which is functional activity actually, by your weight also itself, and smoking cessation or alcohol cessation, and fall prevention. It is very important, like you have to take your eyes. If you have cataract or something, blood vision in eyes, so you have to prevent it also. And if you have uneven surface in your house or your park or whenever you are consuming your time, so you have to be taken care of these also. So it comes in under fall prevention. Again, for osteoporosis, calcium, vitamin D, fruit, vegetables, protein diet, then hormonal imbalance treatment, sodium, and number of things. So again, you have to be take care of all the elements along with not only calcium, vitamin D, combined calcium up to 1.2 gram, vitamin D up to 800 intensive unit can give for the as a regime for the normal population. Again, the osteoporosis is old age disease, so there is a number of documentation for up to over the 50 up to 70-year-old people, and it is around 800 to 1,200. You can average, you can take 1 gram. You can take 1 gram of calcium and 400 milligrams of vitamin D daily basis. Take home message: peak bone mass and bone loss are both important for BMD. We think that these are interchangeable, but not. Peak bone mass is different and bone loss is different. Calcium vitamin D index based on RDA is necessary for the maximizing peak bone mass. Desirable range of vitamin D is 20 to 40 nanogram per ml. Other nutrients include vitamin K, phosphorus, magnesium are important for the bone health. Combined supplementation of calcium vitamin D is recommended for the osteoporosis treatment, but no direct role for the treatment. Supplementation of the calcium vitamin D is not necessary for the primary prevention of osteoporosis. So it is actually palliative for pain relief, for euphoria, for good health, not for the prevention. Thanks. Thank you very much.
Thank you, sir, for a great talk. And diet and nutrition for any health, especially bone health, is very, very important. And this was the last lecture, and we are grateful to you that you accepted the position of last lecture. But never mind, because this is being transmitted live, and we will provide you link. And in our website, it will be put on first number. So then you will get first position. So I am very thankful to the technical staff. We had a glitch sound system problem, so that delayed us, but we finished before time. So thank you very much. Thank you volunteers for doing a great job. I really appreciate, because this is the toughest job. बाहर कॉफ़ी कॉफ़ी पीते रहते हैं, आपको मिलता नहीं है, और you are standing all the time and alert कि टाइम होने वाला है, घंटी बजानी है. तो really grateful. So meet you tomorrow at 9. We are having breakfast, and 10 we are having important panel discussion. So I invite you all, those who are listening on YouTube also, please come in time to enjoy great breakfast and have a great scientific